Hello everyone, welcome to our Zoom meeting. Today we will have different topics that we will discuss, and we're gonna start with Dr. Ayah. She is gonna take the mic from here. Dr. Ayah, when you are ready, please go ahead and start. Thank you.
Okay, Assalamu alaikum. My name is Dr. Ayah, and today I will be talking about public speaking, some strategies and skills. Can you see my screen?
Yes.
Yes, okay. So today we'll be reviewing the basics of public speaking, some preparation techniques, how to engage and interact with your audience, and how to improve your public speaking skills over time. Starting with the basics. So what is public speaking? Public speaking is defined as a speech that involves delivering speeches clearly and purposefully to a live audience. It benefits in improving communication skills, building confidence, and influencing the audience effectively. Speech anxiety is very common, and about 75% of people have experienced that, but it is a very important skill to have, especially in your career. There are many different types of public speaking. Mostly there's the persuasive speeches, such as political speeches, in which the speech aims to influence audiences' opinions using compelling arguments and emotional appeal. So for campaigns, they'd want to influence the audience to vote for them and so on. So that's mostly used in political sense. Informative presentations, like the one that I'm giving right now, which primarily focuses on educating the audience and delivering a clear message. Ceremonial presentations, like the ones in weddings or in celebrations to honor a specific person. And motivational speaking, which inspires and encourages audiences to take action or improve themselves. And there's actually a type of therapy called motivational interviewing, which is used with people who suffer from addiction to help them move on from the addiction and take action of their life. There are key elements for an effective speech. First of all, you should have a clear message. So your message should be clear, focused, and easy to understand and follow. Second, you should have an audience connection. An audience that is connected and engaged with you will retain and remember more of your speech, and it will have a greater impact on them. Body language is very important because, as we know, not all communication is verbal. It's actually 50-50 for verbal and nonverbal communication. So nonverbal cues like your gestures, your hand, how you move your hands, your posture, eye contact, those all play a very important role in audience engagement. And a storytelling power. Some people are natural good storytellers. And as I'll talk about in a bit, when you do use stories, it helps the audience interact with you more. So now let's say we have a presentation coming up. How would we prepare for this presentation? Obviously, first thing we need to do is research. You need to research not only your topic, but also your audience. Researching your topic and reading about it, the more you know, the more confident you are, the more ready you are to answer any questions that might pop up. And this confidence will show while you speak that you are well informed of the topic you are covering. Just like when you're having a regular conversation, let's say someone's asking you about cars and you know so much about cars, you'd be talking with extreme confidence. On the other hand, if you didn't know anything, it will show, even if you're pretending to know, it will show that you don't really know. That's why researching your topic is very important. understanding your audience. Who are you going to present to? Are you presenting to your fellow colleagues, or are you presenting at a school for children? So you'd adjust the material you're presenting or how you present it accordingly, okay? The next thing after researching is practice. As we know, practice makes perfect. The more you practice, the more or the better your presentation will be. So practicing reduces anxiety and enhances the confidence. How would we practice? So a very smart way to practice is to use video recordings. Record yourself giving your speech in a video. That way you can look at it and you have become more self-aware of how you speak or how you walk or your gestures, and you can edit those, which we'll talk about later. Also timed rehearsals, because sometimes you have a 30-minute presentation, you need to make sure that you're in that time frame and you're not overstepping it. So time rehearsals are very important, as well as rehearsing in front of a diverse audience. So you have a speech coming up, you can practice in front of family, friends, whoever is there. Now, once you have the video, for example, or doing it in front of an audience, you'll have some information of what you should be refining, your tone, your pacing, your gestures, as I said before. Now, moving on to the next topic, which is engaging your audience. How would we engage our audience? Engaging your audience involves using verbal and nonverbal communication, because as I said, not all of speak is verbal. It's 50-50. So when it comes to verbal communication, your tone variation is very important, like when you go up in the tone or go low, because if you keep one tone, it's actually called a monotonous speech, and it's used in hypnosis. So unless you want your audience to fall asleep, you have to have some tone variation. Move with your pace, so don't rush it. Try to relax, speak slowly so that everyone can understand. You also adjust your volume into showing how important the message is. As for nonverbal communication, which includes eye contact, gestures, and postures, as I said, this also helps show how important the message is. For example, when you're watching a speech and somebody wants to say something very important, they usually slam the table. So that gesture makes you know that what he's saying next is very important without him actually saying, okay, what I have to say is important. So using an effective combination of both verbal and nonverbal communication skills will enhance your audience engagement. Other ways to enhance your audience engagement is using stories. So when you tell stories, because stories are real life examples, they will create an emotional connection with the audience and make your presentation feel more relatable and more understandable. Using visual aids is very useful as well. For example, having slides prepared, having a video, because that way it's easier to capture their attention because of the pictures. And if you do capture their attention, you increase their attention, and therefore they will remember more of what you're saying. And of course, increasing engagement will increase recall. So have your audience give out comments if they have any questions and other stuff, because if they feel that they are part of the presentation, their attention is better. How would we encourage interaction? By having simply a question and answer session, using polls, maybe an audience participation in a part of your presentation. The more interactive your speech is, the higher the audience satisfaction is. In fact, it's about 30% higher, and your audience will enjoy the overall experience. Using real-time feedback is important. That means don't limit questions or comments till the end of the presentation. If they do have a comment that they would like to share, let them share in real time. This will allow you to adjust very quickly. So let's say the the last row can't really hear you well and they want you to raise your voice. If they waited until the end of your presentation to say that, well, that's not good. So adapting as we go is the best option. Finally, how to improve our skills over time. The feedback we get from ourselves watching the video or from peers or from mentors is something we should take into account and work on, because the only way to actually boost our skills is through positive feedback. And it's shown to improve the skill by 40%. So regardless, it was taking criticism from peers and mentors or your own self by using your video recordings. You become more self-aware. You know where your flaws are, what you can do to fix, what other people thought of the presentation, and therefore you will improve all in all. Learning from others, not only ourselves, is useful. So you can learn from more experienced speakers. There are some workshops that can help you improve your public speaking, or you can just watch some experienced speakers talk and you can take hints and see how they're doing it, or hear from them and how they learn to become more confident speaking. The most impressive talks are TED Talks, so those are really good to watch and to learn of how to present. It's very important to be an adaptive person and to know how to adapt to what's going on. So you can adapt to the room size. You can, like a large room or a smaller room, and accordingly increase or lower your voice. Your audience type, again, are you speaking to educated or non-educated children? Are you going to simplify the message or keep your vocabulary as it is? And your available technology. Let's say I had this slideshow prepared and I showed up and there was nothing I could present on. You can't just panic. No, you have to go with whatever you have available and keep going. Now, when your audience sees that you are a flexible presenter, they'll know that, or they'll feel that you really do know what you're talking about. It will show confidence and therefore increase the audience connection. Yeah, and it will also increase the audience engagement. In these days, we have the modern speaking settings, which in which a speaker has to know how to speak in virtual settings, hybrid settings, and in-person presentation. This is the summary for what we spoke of today. And thank you. Any questions?
Thank you so much, Dr. Ayah. Please jump or raise your hand if you have questions or comments. So I just want to share, this is great presentation. And my experience is when I was in residency, usually they ask you to topic or a case, or even in fellowship, we have weekly meetings. So sometimes you are required to either present a topic, a case, or educate the residents or the medical students. So it's an important skill, and not everyone is equipped with this skill. So it's a matter of learning, as Dr. Aya mentioned. So practice makes it better. Initially, for me, it was nerve, just very anxious producing, something like that, anxiety producing. So what I did, I tried, as Dr. Aya mentioned, look at what other good speakers do. TED Talks, as she mentioned, some videos. I remember I used to look at videos from Malcolm X, or Kalem, or the speakers of the Black movement at the time when they speak. And then later on, there is another way of doing things. So if you are in person, for example, in a room with people you want to talk about topic, one of the tricks is to, it's only in the 10 seconds initially, you will be nervous. So if you cross that bridge, then it's gonna be flow, it's gonna flow easily. So how do you overcome the initial starting point? So one of the trick is to engage the audience. For example, I'm gonna talk today about uh, heart failure. So I'm gonna ask you guys, can you raise your hand if you presented a case about heart failure to medical students? Raise your hand if you do. So some of you might raise their hands, some might not. So this involved, I engage the audience with a question, and then I'm analyzing your body, your response, and putting the anxiety on you instead of on my side, if that makes sense. The other way is, as I said, the ask question, or start with a story. So if you say, for example, I'm talking about heart failure. 20 years ago, when I was in medical school, they were teaching us about heart failure, and they divide heart failure into right side heart failure, left side heart failure, and this and that. But science has changed nowadays. Heart failure is classified in a different way. So you um, tell a story about your topic. It could be a personal story, it could be different stories from the literature. Something that you can make easily or present easily, and then you can start your topic. So there are different ways of using different tricks. One of the other tricks that I learned is to hold stuff in your hand, a penny, a coin, or clip, like a item paper. So you hold it and focus on your hand and then talk. So initially your focus on your hand, so your anxiety goes all the way to your. And as I mentioned, the body language. So if you are counting things, so today we're going to talk about this, this, this. So it makes sense you use your hand to count. So people will understand that first topic will be this. And when you are finishing of the first topic, then you're going to talk about topic number 2 and so on. The last point that my wife teach my kid when they present in school is to use your eyes so that audience can get engaged with you. What I mean is the audience usually in a half circle in front of you or in a one line in front of you. So if you keep your eyes in the middle, then the people on the right or the left, they will not be as engaged, or they don't feel you are addressing their presence. So what you do is you talk starting in the middle, and then you turn your face to the right side to meet the audience on that side, and then look in their eyes while you're talking. And gradually you scan and go to the left side, so you address or you give them your awareness that they are there while you are talking. This is also one thing when you talk in person. Online presentation is a different story. I had that trouble as well, but I learned there are some ways of doing it differently. So one of the tricks is you can use either PowerPoint. They have a tool where you have the slides and you have the speaker notes. So for the speaker notes, you already can just read the notes. So no one will focus on you per se, and you are not focusing on the people you are talking about or talking to. If you have the camera, it might be a little bit tricky. But after all, I think it comes to the 2 points that I mentioned. Review your material. If you are comfortable with the topic, if you search it, if you learn about it, if you know much about it, it comes easy when you are talking. And the second part is your practice. And the more you practice about the presentation or presenting the topic, the better you are. And then as you go along, this will become a skill that comes easily to you guys. So you don't have to work hard. The last story I want to tell you is when you look at this president, let's say president of the United States or any other, they come and talk about stuff, see them confident and so on. They also prepare for these, not presentation, but talks or interviews, because one of the things that you can see is before the interview, they have some papers to read from, or sometimes they start and then they make mistakes and they stop, they redo the thing again, they record the talk again. And when they present it to the public, it's going to be version 2. It's not going to be version 1, if that makes sense. My question to you guys, anyone struggle or have ways of overcoming public speaking? Please share your experience. Thank you.
Because I have experience working in psychiatry, and as you said, it's very common to have anxiety when it comes to public speaking. It's called performance anxiety, and they teach you in books that it's useful and it's okay. And mostly when doing therapy regarding it, they tell you that it's just a wave and it will go away within 5 to 10 minutes. But due to medical practice that I've seen, a lot of, especially medical students, when they have presentations and seminars, they don't know how to get over the anxiety, and sometimes it's more intense in some than in others. So a lot of them would take beta blockers to help them with that, to calm them down. Um, in severe cases, some do require benzodiazepines, but I knew of one presenter that once took that and just got drowsy. It was the worst presentation. So yes, in my experience, the best way is to just let it fade out on its own. No need to go into medication. But as doctors, we like to medicate and to over medicate our patients and ourselves. So that could backfire. It's not always a good idea.
Totally agree. Thank you so much for sharing, Dr. Aya. How about you guys, Dr. Marianne, Malaz, Dr. Heck, Tariq, or Ala? Anyone wants to share? If you're still here. If not, we can move on to the next topic if we have a speaker ready. Malaz, are you ready? Thank you.
Yes, I'm ready. Hello.
Hello, welcome. Please go ahead. Sorry, I forget to add one more thing. When you present, if you use a smile, it will relieve some of the anxiety. Thank you.
Hello, everyone. This screen is clear?
It's coming. It shows the notifications. Oh, yeah.
My name is Malaz Hammour. Today, I will discuss how to improve and optimize care about patients with a fragility fracture from emergency department to long-term osteoporosis management using the latest research-based strategies. We have 77 million baby boomers will be seniors by 2026. 2.1 million osteoporotic fractures occur annually in the United States. Fractures are often silent until they occur, with osteoporosis largely untreated. The aging population is growing faster than predicted. Most patients over 65 have a weakened bone quality that goes undiagnosed until the first fracture occurs. The impact of hip fractures. There are about 330,000 hip fractures per year occur in the United States, with a mortality rate reach about 20 to 24%. Many patients lost their independence post-fractures. They cannot do their daily activities and they depend on their family, nurse, and so on. Annual cost projected that reach to 62 billion by 2040. Hip fractures are the most serious and expensive fragility fractures. Despite their severity, the use of osteoporosis medication after hip fractures had actually declined in recent years. The emergency department phase. Our goal in the emergency department to shorten the stay in this department, identify a medical instability and provide early rehydration, avoid the delay and use the hip fracture order sets to streamline the test. Emergency department overcrowding can be dangerous for elderly patients, promoting delirium and dehydration, so we must move these patients to floor bed as quickly as we can. Clinical diagnosis about the femur fractures usually present with a shortened and externally rotated leg. We can use a conventional radiograph, anterior-posterior pelvis, anterior-posterior lateral hip. If X-ray are negative, but the pain persists, use the MRI to confirm a diagnosis. Avoid whole body CT unless other major trauma is suspected. Standard X-ray remain the best diagnostic method. Pain management strategy. Start the pain control immediately in emergency department. Avoid almepridine in older adult to avoid the delirium. Use a small doses of intravenous morphine or regional nerve block. Effective pain management is humane and reduces the risk of delirium. Traction is generally not helpful for pain and increases the pressure ulcer risk. Preoperative medical assessment. Our target to do surgery within 24 hours of a fracture. Early repair reduces the pain and length of stay and complication. So we focus on optimization, not just clearance. We must move away from a medical clearance mindset. Our goal is to stabilize the patient quickly to allow for early surgical intervention. Cardiac and pulmonary consideration. Our major contraindication, a recent acute coronary syndrome, decompensated heart failure, severe valvular disease, and controlled arrhythmia. Continue a chronic beta blocker, but do not start high-dose beta blocker on the day of the surgery. An echo should only be used if a severe aortic stenosis or pulmonary hypertension is suspected. Routine echo often delay a surgery unnecessarily. If a patient can hemodynamically stable and can climb a flight of stairs, they are generally ready for a surgery. We can proceed the surgery if INR was less than 1.5. Use oral vitamin K or fresh frozen plasma for rapid reversal for warfarin if a patient use it. Newer anticoagulant like a dabigatran may require a 48-hour wait. So a fresh frozen plasma is the fastest way to reverse a warfarin and significantly reduce time to surgery. For a newer medication, we have this table. These summarize the common medications and their specific reversal agent and time it need, like warfarin, vitamin K, and 4-factor prothrombin complex concentrate. For apixaban, we use also factor 4 prothrombin complex concentrate and dexinat and so on. Regarding nutrition and hydration, isotonic saline 100 to 200 milli per hour for rehydration, avoid the volume overload. Prioritize oral feeding, avoid an edogastric or a parenteral feeding because a risk of delirium and sepsis. High calorie, easily chewable supplements are beneficial. Malnutrition is common in elderly and delay healing. A multidisciplinary nutritional approach leads to better outcome and lower mortality. Preventing a common complications, avoid ethers, catheters, restraints, use a glass and hearing aids. Pressure ulcers, prevented with the use of low-pressure mattress, perform skin exams on admission, and infections document and treat symptomatic UTI. Delirium and pressure ulcer are often iatrogenic. Simple measures like ensuring the patient has their hearing aids can drastically reduce this risk. Multidisciplinary care unit, a core team, orthopedics, geriatrics, medicine, anesthesia, nursing, and a therapist. The mid-level practitioner act as a central coordinator, like a nurse, مثلا, interdisciplinary rapid round to manage a daily plan. A coordination is the key, having a dedicated person to bridge the gap between surgeon and a medical team reduces the error and length of stay, like hop and spook يعني. Rehabilitation and discharge, early mobilization, aim for mobilization on a day of a surgery. Medicare requirement, 3-day inpatient stay. For FNF coverage in the United States, patient education, one-step instruction are best for those with cognitive defects. A physical and occupational therapy should be individualized. Family members must be included in training, as they will often be the primary caregiver. Secondary prevention for osteoporosis, identify a fracture at a fragility fracture to trigger a treatment. Use an FRX FRAX tool to assess a 10-year risk for fragility fractures. Discharge a patient on calcium and a vitamin D supplement to reduce a fracture. We must capture these patients while they are in a hospital. A single fragility fracture is the strongest predicator of a next one. We must treat the underlying osteoporosis to avoid fracture next time. In conclusion, by implementing this system, we can move from fragmented care to streamlined process that saves lives and resources and reduces a fragility fracture. Thank you.
Thank you so much, Dr. Malaz, for great presentation.
Welcome.
Yeah, I think it's an important topic and it's common. And as you mentioned, in the US, the general population, older people are increase in number. So we expect more and more injuries or falls and fractures, especially in weather like winter weather, where when people go outside on ice and then fall and fracture. Thank you. It's an important topic. Any questions to Dr. Malaz from the audience? If not, we can move on to the next topic. I don't see Dr. Hala. And we are waiting for Dr. Malaz, the other Malaz, Malaz Salah. So in the meantime, I know maybe some of you or other fellows are applying, and I think in these days we will hear about who got accepted in the residency. Anyone of you applying this year? Can you share your experience, what's going on and what's the plan? Or if you are planning to apply next year? Thank you. I'm going to start with you, Dr. Ayah.
Well, inshallah, I'll take my exams, and I'm not actually planning on doing a residency again because I've already done that. I'm planning on going straight for a fellowship, and we'll see what happens afterwards. But inshallah, I'll continue in psychiatry. It's my true calling, as they say.
Sounds good. So you need to, yeah, if you can do the steps 1, 2, 3,
Yes, up to
of the
3.
plan, yeah.
Mhm.
And if you connect with people in the field,
Mhm.
if you have some experience here in the US, if you are volunteering here in the US, I know Dr. Myra, she was one of the fellows in this program. I think she is either second or third batch, I think, cohort group. She was also interested, and she worked with, as I said, the step 3. She participated with some volunteering, had some experience, and actually she matched, I think, last year or the year before. And we have other people from this program also match directly to the residency. But as you mentioned, there is a way to do it if you want to go to fellowship first and then go to the residency. I wish you all the
Inshallah.
best, inshallah.
Thank you, Dr. Nader.
Sure. And I forgot to mention, publish as much as you can in the field. So posters, papers, anything that also might help. Anyone else? Go ahead, Ayah.
No, just thank you. Thank you very much.
Thank you. Go ahead,
Good
Dr.
evening.
Ayah. Yes.
Hi, Dr. Nader.
Hello.
رمضان كريم.
رمضان مبارك. ربنا تقبل.
اللهم آمين يا رب العالمين. Hi, everyone. My name is Dr. Ala, and I'm planning to apply to the residency. I already took my exams, step 1 and step 2, and I succeeded, alhamdulillah.
Alhamdulillah.
But yes, the only obstacle I have here that I'm not currently living in the United States. So this is why I'm a little bit like hesitated about applying. But we'll see. Maybe in the next cycle, yes, it will be more clear.
Sounds
Yes,
good.
I'm planning to apply to internal medicine program.
Sounds good. Where are you located now?
Egypt.
Egypt. Okay. Yeah. Just
Yes.
you can do the same practice there if you have opportunities. Volunteer if you have opening there. Also do your research work, posters or in any type. Yeah. And I wish you all the best as well.
I will try. I'll try, inshallah. Thank you, Dr. Nader.
Thank you, Dr. Anna. Wish you all the best. I see Dr. Hala is here. Dr. Hala?
Hello, Dr. Nader. How's everyone? Hello, Dr. Ala, Dr. Hajer, Dr. Malaz, Dr. Lina and Aya, and Dr. Marian. How's everyone?
Good so far, alhamdulillah.
Alhamdulillah, I'm so sorry. By the way, I was stuck in the UAE with all what's happening in the UAE, and I was trying to land in Egypt. So I finally landed in Egypt today, and it was really hectic, but Alhamdulillah, everything is
Yeah,
fine now. And also, I couldn't, to be honest, I couldn't hear the meeting, all of it, because we do have like guests over now. So I'm
okay.
sorry if I didn't, I
That's all
couldn't
right.
hear everything.
That's okay.
Yeah, so I have a presentation that I will be presenting today. So let me know if I can start.
Yeah, when you are ready, please go ahead. Thank you so
Oh,
much for.
all right, thank you. I'll just need like 2 minutes to share my screen and we will start.
Sure.
So can everyone see the screen? Is it
Do me a favor, just flip the phone to the side way. Yeah.
okay? Just a second.
Phone.
I don't really know how it looks now, but I hope it's like I hope it's clear. I tried to flip it, but I really hope it's clear for you.
That's okay. Yeah, go ahead.
Okay. So today I'll be talking about the Anova test and like the basics and tools. But before starting this presentation, I wanted to talk about ANOVA, and I've always like heard the word ANOVA like in statistics, but I didn't really understand at that time. Like I didn't really understand why is it so important, and like and then when I started learning about it, I realized that ANOVA is like actually very useful. It's like a very useful tool for answering a lot of questions, for like a very simple question like for example, are these groups really different, or is this difference just random? So when I started learning about it, I knew that it's actually a very interesting tool. So today I will walk you through the basics of ANOVA and how it works and the tools and like the tools that are used to apply it like in real data analysis. Okay, so this is an introduction to ANOVA. So ANOVA stands for Analysis of Variance. So it's a statistical technique. It's used to compare the means or averages or of 3 or more groups. And for example, let's just say, imagine we want to know if different teaching methods affect student exam scores. And like instead of comparing each pair of groups separately, like separate, ANOVA actually allows us to like analyze all of the groups together. So this kind of helps like researchers to determine if there's like a difference between the groups, or like are there actually a real difference, or it's just like a random difference. So we want to know why why do we need ANOVA? Like, why do we need it, or when do we want to use it? So if we are comparing groups, for example, we know that we can use a t-test, a test called t-test. But the thing about t-test is that t-test only like compares two groups at a time. But like, what if we have many groups? Like, if we have many groups and we perform many t-tests, this will, like, if we have a lot of groups and we did the t-test, this will cause like an error, a type 1 error. And this means like this will the false positive will become higher if we use that t-test for many groups. So what ANOVA does is ANOVA like kind of solves the problem by comparing all groups at a single, like in a single test. So what's really good about this is that ANOVA reduces the errors and gives you like a more reliable result. Okay, so the basic concept of ANOVA. So now we know that ANOVA compares two types of variants. So how it does that, like how it compares the two types of variation, is that first there's a between group variance. So this like measures how different the group averages are from each other. That's the first thing. And then the second is it's something that within the group variance, and this which measures like how much the values vary inside each group. So if the variation between these groups is much way like larger than the variation within the groups, this suggests that the groups are actually different. So large between group variance, this suggests like there's a real difference between the group. Okay, and then so now we're going to talk about the hypothesis. And like most statistical tests, ANOVA uses hypothesis testing as well. So we know that the null hypothesis, which is like written as the H0, this assumes that all groups means are equal. And then we have the alternative hypothesis, which is the H1. It's written as H1. This says that at least one group mean is different. Okay, so now at this slide, the F statistic. So ANOVA actually uses something called the F statistic to measure differences. So the F value, which is calculating by dividing the variance between groups by the variance within the groups. So to repeat that again, the F, how do we calculate the F value is basically calculating, basically dividing the variance between the groups divided by the variance within the groups. And if the F value is large, then this means that the groups are likely different. So after calculating when you like calculate the F value, and then after that we look at the P value. And when you look at the P value, which is it's smaller than the chosen significance level, which we know that it's usually like 0.05, we will reject the null hypothesis. Okay, now we should also know that there are types of ANOVA. So there are several types of ANOVA depending on the study design. And the first is called one-way ANOVA, which analyzes like one independent variable. And for example, one independent variable, for example, could be comparing exam scores across 3 teaching methods. That's one independent. And then the second type, which is a two-way ANOVA, this analyzing 2 independent variables. So going back, one way means 1 independent, and then two-way ANOVA means 2 independent variables. And that's, for example, you analyze different independent variables. For example, you can take teaching method as a variable and study time as another independent variable. And then the third type is called repeated measures ANOVA, and where the same participants are tested multiple times under different conditions. Okay, so this is a table. So ANOVA results are usually summarized in something called ANOVA table, which is this table. So this table shows different sources of variation in the data. For example, we see here variation between groups, and we see variation within the groups, and then at the bottom, which is the total variation. So between groups and within groups and total. So from these values, we calculate the mean squares and the F statistic. So this tells us whether the differences between the groups are significant or not. Okay. So we need to know that there are many tools. Like today, ANOVA calculations are usually performed using statistical software. So you will find ANOVA in SPSS. You're gonna find it in R programming, and there is something called Python, and also Microsoft Excel in that. So these tools automatically calculate the F value, so you don't need to calculate it. So we all know that, yes, SPSS, and yeah, they calculate the P value and ANOVA table. So this like makes the analysis faster and more accurate. Okay, so there are a lot of advantages to ANOVA. So first, it allows like researchers to compare multiple groups simultaneously. So that's the first thing. And the second thing is that ANOVA actually reduces the risk of type 1 error. And we talked about that earlier, that this can happen when we perform many tests using the t-test, as we mentioned earlier. And then finally, it's widely used in research fields such as like science, economics, and like social sciences and all of that. So you can, yeah. And then here, we can say that there's a few limitations of ANOVA. ANOVA only tells us that there's a difference. Like ANOVA will tell you that there's a difference that exists, but it does not tell us which specific groups are different. So this might be something that we can think about. And to find out, in order to find that out, we need like additional tests, which is called post hoc tests, and such as Tukey test. Actually, I didn't. When I studied about ANOVA, I just knew these 2 tests exist. Actually, I didn't know about the post hoc tests and the Tukey test, but I knew that these are like additional tests that are done to find out which specific groups are we talking about. And then lastly, ANOVA requires like certain assumptions about the data, and if those assumptions are not met, the results may be like less reliable as well. So in conclusion, to conclude, so we know that ANOVA is a powerful statistical method for comparing multiple groups. And we also know that it works by analyzing the variation in the data, and and we also talked about the F statistic and how F statistic is used to determine whether differences between groups are significant. And because of its ability to analyze like multiple groups at once, like at a time, ANOVA is widely used in research, experiments, and data analysis, and all of that. So I think it's it's a pretty important test. And thank you so much.
Thank you so much, Dr. Hala, for also great presentation. It's a good tool that you need to know when you are doing analysis. Good.
Thank you.
Thank you so much.
Hi, I just want to add something for Dr. Hala.
Go ahead.
Yes, regarding the post hoc analysis. I read about it when I was studying for step 2 in the statistics chapter. And the post hoc analysis is just done when after the primary study finished and everything is done. Then after that, they study the subgroups of the study itself. So this why there is like it said it's not very powerful study because it's not was in the beginning of the study, like it was not in purpose of the study. This is why it's not very, very powerful analysis, the post hoc. However, it is used for the ANOVA study at the subgroups of the study. This is what I read about.
Thank you so much, Dr. Ala. Thank you for that.
You're welcome.
Thank you both. Any questions for Dr. Hala? If not, we can move on to the next topic. Is Dr. Malaz Salah here or not yet? If not, that's fine. Let's talk about the program, this fellowship. Do you have any questions, guys? Do you have any thing unclear? Anything we can improve? Anything we can change about this program? Please go ahead and share your thoughts. Or if you'd like, maybe you can share updates if there is any project that you are doing, or if you are working on new ideas. Can you share?
Dr. Nader, I wanted to share something.
Yes.
So when I first joined the program, I wanted to like expand my knowledge about research and to get more information about how to do research and all of the different types of research and everything. And then I joined my group, let's say my subgroup, but I didn't join any research project until now. And I don't know how people start the project, because I thought we have a group, a group on WhatsApp, but there's no any ongoing projects, or I don't know. Like, is the group leader, is he the one who's supposed to like share any projects or something, or how do I join a research project?
A good question. Thank you for asking, Dr. Hala. So basically, it depends on you and your interest. The group leader can help, but you can do it yourself. So how to do it yourself? I'm going to share with you the screen here. If I just get this. So if you go to the app itself, there is a way to go to projects. And then in this list, if you are interested in certain things, I'm interested in dementia, for example, then you might have some topics that are there. You can read about the topic, and if that suits you, then you can add your name to the project. The other way around is to, if you have a new idea, you can share it with the group in the WhatsApp and see who is interested, and then you can take it from there. So let's say you are interested in AI and dementia. So mention that in the WhatsApp group, and maybe you will find some people who are interested in the same topic. This is the first or initial step that you can do yourself. There are two ways of doing it. One is you bring the question or the research idea by yourself. Let's say you want to complete the AI in dementia in nursing homes in the last or during COVID, for example. So you created the topic or the idea of the research, and then the next step is to create a team, and with the team, then you identify the task or what next. So I have the idea. I want to research this idea. Is it done before? If it's done, how can I modify, bring something new to the table? If it's not done in the past, then what's the best method that I can use to run this project, and so on. And then when you have final plan, then identify the task, divide it between the group, if you have the team, between the team members, then you can work and set the timeline and so on. So this is straightforward if you have an idea, and if you have the know-how to, the steps to doing a research project. Let's say you just graduated from medical school, you work in a hospital for some time, and you wanted to join because you don't know the steps of doing the research from A to Z, or you don't have an idea, but you have interest in a certain field. Let's say you are interested in AI and dementia, but you don't have a clear question in your mind. So you ask the group as well, see who is working in a project that target either the dementia, the AI, or both of them, and see maybe there are some people who are still working on some project similar to your interest. If you find some, then you can join the ongoing process if there is already a research undergoing in the meantime. So these are the ways that you can use a WhatsApp group to help you either create a team or join a team. And these teams are not necessarily your team, like the blue team, the color. You can join any other ongoing team that are working, not necessarily in your group. In the past, some of the team leaders, the blue or the red team leaders, they are interested and they divide the team into subgroup, let's say A and B, and then they find some questions and then created projects for team A and team B, and then they work on for example, systematic review. And the topic, the team A will talk about this, systematic review, and then they will start from A to Z. And then also for the other subgroup, group B, for example. So the team leader can get involved and can teach and can help identify things for the team members in their color. That's another way of doing things. It depends on how active the team leader and if they are motivated and know how to, and they want to get the team involved. So some of the teams work within the team color that we divide you into, if that makes sense.
Yeah. All right. Thank you so much, Dr. Nader.
You're welcome. The third option is you can do it by yourself and then ask teams to help. And with the AI available, let's say I'm talking to Dr. Ayah, for example, she is interested in pursuing psych. So what I would say, if she is interested in developing a project, she will go to AI and then whatever Gemini, any tools, then ask what is the gap in whatever topic that she is interested in, let's say schizophrenia, in the research area. So the AI will list some of the gaps in research that are not addressed. Then she can say, limit them to 5 research ideas. Then the AI will list 5. Then she will select one of these topics and say, elaborate on this. So it will elaborate a little bit. Then you can say, I want to build a research project around this. What the whatever background that I need to find out about this topic. Then it will list you some of the literature that you want to read, some references, and so on. It will help you go step by step. It may suggest you some methods you can agree or disagree, and then work on your project with the AI. That's another way. And in the meantime, you can also see if there are other people interested in the same topic and you can work together. That's a different way. One of the ways that in the past we did is look at a conference where you are interested to present. Let's say there is the American Geriatric Society. If you want to go to family medicine or internal medicine, you look into their website, look at last year or the year before or several years before, see what topics were presented as poster, for example. If you find something that's interesting and people presented it 5 years ago, then you have a 5-year gap. You can do the same topic that was 5 years ago and see what, if you can find any difference, what's the new knowledge you can get. People will look at things COVID and after COVID, hospitalization and so on, something that you can find in the literature people already did, but you wanted to modify either, let's say, the timing, so you want to add time, as we mentioned, or location. If they did it in, let's say, a state, they did something in Michigan, and they presented that topic, and the population that in that topic was Michigan. But let's say Hala or Ayah is interested, but she is in Louisiana. So she can pick that topic and apply it to the population in Louisiana and see if the result similar or it's different. What could be the difference there? And then she can present that, if that makes sense. So there are different ways of doing research project. Depends on your time, interest, and how you want to pursue. If that makes sense. Thank you.
Thank you so much, Dr. Nad. Thank you.
Thank you. I see Dr. Malaz here. Welcome, Dr. Malaz Salah.
I'm also here, Dr.
Yeah,
Nader.
Dr. Nader.
Dr. Ahmed, yes. Welcome.
Sorry for being late. I have to finish Tarawih prayer. I'm so
Yes.
sorry for that.
And that's fine. We expected that. That's fine.
Thank you so much.
Thank you.
I will start the meeting. Thank you so much, Dr. Nader. Good morning, good afternoon, everyone. Welcome to today's session. My name is Dr. Ahmed Khalifa. I am the team leader for the Canary team, and I will be moderating today's meeting. Today we have a diverse and engaging agenda that touches on clinical care, especially for geriatric group, research methodology, digital health tools, and professional development. I'm looking forward to meeting you today Let's begin with our first topic, and it will be about chronic care management with Dr. Malaz Salah. Before we start, as you know, chronic care management is an essential component of modern healthcare, especially in geriatric. Patients, as you know, often live with multiple chronic conditions requiring coordinated and continuous care. Understanding these models will help us to improve outcomes while supporting patient independence. Let's welcome Dr. Malaz Salah.
Thank you so much. Go ahead, Dr. Malaz.
Dr. Malaz, are you here?
She was here, but I think she stepped away for a second. We'll give her some, she's back. Dr. Malaz, you are muted if you started talking. Thank So,
Dr.
Dr.
Malaz, can you hear me?
Hello, can you hear me?
Yes.
Oh, I'm sorry. Okay, let me just share my screen. Is it clear?
Yes.
Hello everyone, I'm Dr. Malaz Salah. Before starting, I would like to thank Dr. Nadir for his ongoing support and for the effort he puts into building this such a valuable learning space where we can exchange ideas, collaborate, and continue growing as fellows. And I would like also to extend my appreciation to Dr. Mohammed, our team leader, for his guidance and coordination through this program. And also my thanks to all the fellows participating in this fellowship, whose thoughtful discussions and shared perspectives truly enriches this learning experience. And before starting, I would like to acknowledge that the main resource for this presentation was adapted from the Jamuthy and supported by ACL, the Administration for Community Living. And this resource provides an excellent framework for understanding how chronic care management moves from planning into real-world implementation. So I would like to begin with a simple reflection about the way we participate medicine today. As healthcare professionals, many of the moments that stay with us the most are the urgent and dramatic ones. Emergency situations, critical cases, and the rapid decisions we make that can immediately change the patient's outcome. These moments are powerful and they are essential part of the clinical medicine. However, when we take a step back and look at the broader reality of healthcare today, we begin to notice something very important. The majority of the patients we care for are not dealing with a short-term illness. Instead, they are living with chronic conditions such as diabetes, hypertension, cardiovascular disease, chronic respiratory diseases, and many other lung health challenges. These conditions often accompany patients for many years and sometimes even for their life. So because of this, managing chronic disease requires something very different from teamwork among providers, activation engagement, and healthcare systems designed to support patients over time. And this is exactly where CCM is not only about treating disease, it's about creating a structured, coordinated, and patient-centered approach that helps patients manage their condition, prevent complication, and ultimately improve their quality of life. And in many ways, chronic care management represents an important shift in healthcare, moving from reactive treatment to proactive, coordinated, and continuous care. So before we explore this concept further, let me briefly walk you through the objectives of this presentation. In this presentation, we'll begin by understanding the chronic care management operations process and how healthcare teams organize and coordinate long-term care for patients living with chronic diseases. Next, we will explore the contract models that support CCM programs and enable healthcare systems to structure and sustain coordinated care services. After that, we will discuss the value-added benefits of chronic management, not only for the healthcare system and providers, but most importantly for patients, particularly those living with multiple chronic conditions who require continuous care and support. And finally, at the end of the presentation, I will open the floor for questions and discussion so we can reflect together. So let's start by looking at where chronic care management actually exists within the healthcare system. As we know, chronic care diseases are becoming one of the biggest challenges in healthcare today. Patients are living together, but many of them are also living with multiple chronic conditions that require ongoing care and long-term follow-up. And because of this reality, many healthcare organizations are now looking for better ways to manage these patients more effectively. And this is exactly where chronic care management programs come in. So on this slide, we can see the main organizations that typically use CCM services. Let's start with health systems that are trying to reduce hospital readmissions. As we know, many patients with chronic diseases such as heart failure, diabetes, or COPD are frequently admitted to the hospital. But the challenge is that after discharge, many of these patients may not receive enough follow-up support. They may struggle with medication management, life changes, or understanding their treatment plans. And because of that, they often end up returning to the hospital. So CCM addresses this problem through regular follow-up care or coordination, patient education, and ongoing monitoring. CCM programs help healthcare teams identify problems early and prevent avoidable readmissions, and ultimately, this improves both patients' outcome and healthcare efficiency. And another important group is accountable care organizations or ACOs. These organizations are designed to bring together doctors, hospitals, and other healthcare providers to deliver coordinating high-quality care. Their main goal is not only to treat patients, but also to improve health outcome while controlling healthcare costs. And actually, CCM fits perfectly with this model because when care is coordinated, patients are monitored regularly and chronic diseases are managed proactively. Healthcare systems can avoid unnecessary hospitalization and complications. So for ACOs, CCM becomes a very valuable strategy. Now let's look at physician practices that are owned by health system. These practices often care for large numbers of patients with chronic conditions. But managing these patients can be complex, especially when care involves multiple providers, different medications, and long-term treatment plans. So CCM help create a structure. It allows these practices to organize care plans, track patient progress, and maintain regular communications with patients. And this leads to better continuity of care and strong patient-provider relationships. And another important setting is multi-specialty practices. As we know, patients with chronic illnesses often need care from different specialists. For example, a patient with diabetes may see an endocrinologist, a cardiologist, nephrologist, and a primary care physician. But without coordination, care can easily become fragmented. And actually, this is where CCM becomes very powerful. It helps connect these different providers through a coordinated care plan, ensuring that everyone involved in the patient's care is working towards the same goals. And finally, physician groups that participated in bundled payment models. In these payment models, providers receive a single payment for managing a patient's entire episode of care rather than being paid separately for each service. So naturally, providers are motivated to focus on quality, efficiency, and prevention. And CCM supports this by helping healthcare teams managing chronic conditions more effectively, reduce complications, and prevent unnecessary hospital visits. So overall, what we see here is the chronic care management is not limited to one type of healthcare organization. Instead, it has become an important strategy across the healthcare system, helping hospitals, physicians' practices, and healthcare networks provided more coordinated and patient-centered care. The next important idea is understanding how this model actually creates a win-to-win situation for different partners in healthcare system. Because in CCM, success does not depend on one organization alone. It actually depends on collaboration between healthcare providers and community organizations. And when these collaborations works well, both sides benefit, and most importantly, patients receive better long-term care. Let's start with the provider side. As we know, physicians and healthcare teams are often overwhelmed, and physician and healthcare teams are often overwhelmed with the growing number of patients who live with chronic diseases. And managing these patients effectively require more than just clinic visits. It requires continuous follow-up, education, lifestyle guidance, and long-term monitoring. And this is exactly where the CCM can support providers. And additionally, care management resources to support patients. So CCM programs, provider gain additional care management resources that help support patients outside the traditional clinic setting. For example, care coordinators, health coaches, or community-based programs can assist patients with medication adherence, monitoring symptoms, and managing their conditions more effectively. And this means providers are no longer working alone. They have a broader support system helping patients between visits. Another important benefit is the CCM helps extend self-management and lifestyle interventions beyond the clinical walls. And as we know, many chronic diseases are strongly influenced by lifestyle factors such as diet, physical activity, stress management, and medications adherence. But these behaviors happen in patients' daily lives, not inside the hospital or clinic. So CCM programs help bridge this gap by connecting patients with community resources and programs that support healthier behaviors in their everyday environment. And from a healthcare system perspective, CCM also helps providers meet important quality and performance measures, such as MIPs and ACO requirements. So these programs evaluate healthcare organizations based on quality of care, patient outcome, and cost efficiency. By improving care coordination and prevention complication, CCMs help providers achieve better outcomes while also controlling healthcare costs. So from the provider's perspective, CCM support both clinical quality and system efficiency. But the benefits of CCM are not limited to the healthcare providers. In fact, community organizations also play a very important role in this model. And community-based organizations, or CBOs, are essential partners in chronic care. These organizations often work directly with patients in their communities and can provide programs that support health prevention and lifestyle changes. One of the key advantages of the CBOs is the opportunity to develop a revenue generation service line. By participating in CCM programs, community organizations can offer structured health support services such as chronic disease, education, lifestyle coaching, and self-management programs. This allows them to both expand their impact in the community and sustain their service financially. Another important benefit is the creation of a direct referral pathway for evidence-based program. So healthcare providers can refer patients directly to community programs that are designed to help manage a chronic condition. This means patients can receive additional support outside the clinic, such as the lifestyle programs, support groups, or disease management education. And finally, these collaborations create a scalable care model that can be replicated across different healthcare systems and communities. In other words, once a partnership between providers and community organization is established, the model can be expanded and adapted to serve larger population. And this makes CCM not only effective at the individual level, but also sustainable at the population health level. So when we look at the bigger picture, CCM creates a real win-to-win partnership. Providers receive additional support to manage complex chronic condition. Community organizations gain opportunities to expand their programs. And most important, patients receive more coordinated and continuous care. So, after seeing how CCM creates a win-win partnership between providers and community organizations, the next logical questions becomes, how are the patients that these programs are mainly designed to serve? And from the payers' perspective, the answer is actually very clear. CCM programs focus primarily on patients with the highest healthcare needs and the greatest risk of complication. So when we talk about the target population from the payer perspective, we are mainly referring to individuals who are enrolled in Medicare programs, especially those who are living with multiple chronic conditions. And as we know, these patients often require frequent medications and the ongoing monitoring and coordinated support across different healthcare providers. So let's start with Medicare Part B beneficiaries. Medicare Part B typically covers outpatient services, physician visits, preventive services, and many aspects of chronic diseases management. And because CCM services are usually delivered outside the hospital through ongoing monitoring, communication, and care coordination, many of these programs are closely linked to Medicare Part B coverage. Now, within this population, there is often a special focus on dual eligible beneficiaries. These are individuals who qualify for both Medicare and Medicaid, which usually means they are older adults or people with disabilities who also have limited financial resources. And actually, these patients often face more complex health challenges, including multiple chronic diseases, social barriers, and limited access to healthcare support. Because of these challenges, research consistently shows that dual eligible population tend to have a higher healthcare costs and a greater burden of disease. In other words, these patients often require more medical services, more hospitalization, and more long-care support. And that is exactly why CCM programs focus on them, because better coordination of care can significantly improve outcomes while also reducing unnecessary healthcare costs. And another key focus is on individuals who are living with 4 or more chronic conditions. As we know, as we can imagine, managing multiple chronic diseases simultaneously can be extremely complex. A patient may be dealing with diabetes, hypertension, heart disease, and chronic kidney disease all at the same time, and without coordinated care, this often leads to fragmented treatment plans, medication conflicts, and frequent hospital visits. So CCM programs help bring structure and coordination to these complex cases, ensuring that care remains organized, proactive, and patient-centered. But Medicare Part B is not the only payer environment where the CCM plays an important role. Another key populations comes from Medicare Advantage programs. So Medicare Advantage plans are private health plans that provide Medicare benefits through managed care models. These points are particularly focused on improving care quality, preventive services, and population health outcomes. And because of that, CCM programs are highly relevant in this setting. And within Medicare Advantage populations, there is often a strong emphasis on low-income subsidy recipients. These individuals may face additionally financial or social challenges that affect their ability to manage chronic conditions effectively. So providing coordinated care, education, and support through CCM programs become even more important for maintaining their health and preventing complications. And actually, studies from CMS, the Centers for Medicare and Medicaid Services, have shown a clear relationship between subsidy status and HEDIS performance outcomes. And HEDIS measures are used to evaluate the quality of healthcare services, include chronic disease management, preventive care, and patients' outcomes. What this means is that when healthcare systems invest in programs like CCM, they can improve these performance measures while also delivering better long-term care for vulnerable population. So when we look at the all picture, CCM programs are strategically designed to focus on patients who need coordinated care at most. And these are individuals with multiple chronic conditions, complex healthcare needs, and often additional social or financial challenges. And by targeting these populations, CCM programs can make meaningful difference, improving the patient's outcomes and reducing unnecessary hospitalization and creating more sustainable healthcare system overall. So let's now look at the target population from another a very important angle, the disease groups themselves. And actually, this slide shows us something very important. CCM is not only designed for patients who have chronic disease, but especially for patients whose health is influenced by the way they live, the conditions around them, and even their mental health. So in other words, CCM focus on people who need more than prescriptions. They need continuous support, behavior change, coordination, and follow-up over time. So let's start with the first group, diseases that are strongly impacted by the lifestyle choices. As we know, many chronic diseases do not develop or worsen in isolation. They are often closely linked to daily habits such as diet, physical activity, medication adherence, sleep, smoking, and stress. And this is exactly why CCM is valuable because it goes beyond treating the diagnosis itself and helps support patients in managing the behaviors behind the disease. One very clear example is diabetes. Diabetes is not managed by medication alone. It requires daily decisions, what the patients eat, how active they are, whether they monitor their blood glucose, whether they take their medication correctly, and whether they understand how to respond to symptoms or changes in their condition. So if we think about it, diabetes management is really long-term partnership between patients and healthcare team. And that is why CCM fits so well. It helps patients stay connected to care, receive education, follow a care plan, and address problem early before they become serious complications. So here CCM supports both clinical control and self-management. The same applies to heart disease and especially heart failure. These patients often need close follow-up, medication adjustment, dietary restriction, some symptoms monitoring, and clear recognition of warning signs such as fluid overload, worsening shortness of breath, or reduced exercise tolerance. And actually, small lapses in self-management can quickly lead to major consequences, including emergency visits or hospital admissions, as we know. So CCM becomes very important because it helps create a system of regular follow-up and patient support. In other words, it helps shift care from reacting to deterioration to preventing deterioration in the first place. But lifestyle is not only the part of the picture. Sometimes the biggest challenge is not the disease itself. As you know, it's the environment the patient is living in. This brings us to the second major group, populations affected by social determinants of health. As we know, the health is not shaped only by biology or medical treatment. It's also shaped by very real factors such as income, education, transportation, access to healthy food, housing, family support, and access to healthcare services. So even when two patients have the same diagnosis, their outcomes may be completely different depending on their conditions in which they live. And this is why CCM is especially important for the socially vulnerable population. Let's start with low-income populations. Patients with limited financial resources may struggle to afford medications, attend follow-up visits, maintain healthy nutrition, or access preventive care. So even when the treatment plan is medically correct, the patients may not be able to carry it out in real life. And that is where CCM can make a real difference. It helps identify barriers early, connect patients to support services, and provide more practical and individualized care that fits their real circumstances. Another important group is minority population. This group may face disparities in healthcare access, communication barriers, reduced trust in the healthcare system, or unequal health outcomes because of long-standing structures and social factors. So CCM is important here, not just because these patients have chronic disease, but because they may need more intentional care coordination, better communication, and culturally sensitive support. And in this way, CCM can help move care toward greater equity, not just greater efficiently. And then we have rural populations. Patients living in rural areas often face challenges such as fewer healthcare facilities, long travel distances, limited specialist access, and delayed follow-up. So for them, continuity of care can be difficult even when they are motivated to engage in treatment. So CCM helps address this by strengthening follow-up system, improving coordination, and supporting long-term management even when access is limited. So again, the goal is not simply to diagnose disease, but to make sure care remains connected over time. And then there is another group that we absolutely cannot overlook. Patients living with depression, because mental health and chronic diseases are often deeply connected. This third group includes population who have primarily or secondary diagnosis of depression. And this point is very important because depressions can affect almost every part of chronic disease management. A patient with depression may struggle with motivation, medication adherence, physical activity, attending appointments, or even the emotional energy needed to manage their condition. So even if the medical plan is appropriate, outcomes may still suffer if the patient's mental health is not addressed. And that is exactly why this group is highly relevant to CCM. And CCM encourages a more model of care, one that recognizes the emotional health, physical health, and long-term disease outcomes are all connected. And as the slide highlights, according to WHO organization, depression is one of the leading causes of disability worldwide. This reminds us that depression is not a minor or secondary issue. It's a major public health challenge that can significantly affect quality of life, daily functioning, and chronic disease outcomes. So when CCM includes patients with depressions, it reflects a much more human and realistic understanding of healthcare. So when we bring all this together, this is like telling us something very important. The target population for CCM is not defined only by diagnosis, includes patients whose conditions are shaped by lifestyle, social determinants, and mental health challenges. And that is why makes CCM such a meaningful model of care. It does not simply ask what disease does this patient have. It also asks what is making this disease harder to manage in real life. And once we start asking that questions, care becomes more coordinated, more compassionate, and more effective. Okay, the next natural questions becomes, how do we actually start implementing CCM in real clinical practice? Because moving from the idea of coordinating care to actually building a working systems requires planning, collaboration, and the right structure. And this is exactly what this slide is about, how to pilot the CCM process step by step. Let's begin by the first, perhaps one of the most important steps, seeking out a champion. Every successful healthcare initiative usually starts with something who truly believes in the vision and is willing to drive the change forward. In the context of CCM, a champion would be a physician, a nurse leader, a care coordinator, or even a healthcare administrator who understands the value of long-term care coordination. This person helps advocate for the program, motivates the team, and ensures that implementation continues moving forward even when challenges appear. So in many ways, the champion becomes the someone that keeps the initiatives moving. Next comes something equally important, developing a model for sharing clinical data. As we know, chronic care management relies heavily on information. Healthcare providers need to know what medications that patient is taking, what conditions they are managing, what services they are receiving, and how their health is evolving over time. But if information is fragmented between different providers, different systems, or different organizations, care becomes disconnected. So CCM requires a structured way for providers or community organizations to share relevant clinical information safely and efficiently. This allows everyone involved in the patient's care to work from the same picture and make better coordinated decisions. And once the data systems are in place, the next step is identifying the right participant for the program. Not every patients will require the same level of chronic care management, as we know. So healthcare teams need to develop a process for identifying patients who would benefit most from these CCM services. So typically, these are patients with multiple chronic conditions, frequent hospitalizations, complex care needs, or high risk of complications. By targeting the right population, CCM programs can focus their resources where they will have the greatest impact. Another important step involves building understanding and collaborations between partners, particularly between providers or community-based organizations or CBOs. Often these groups operate in a very important environment. Healthcare providers are focused on clinical care documentation and medical decisions making. Community-based organizations, on the other hand, often focus on social support services, lifestyle programs, and community outreach. For CCM to work effectively, both sides need to understand how the others operates, their workflows, their goals, and their constraints. So this step is really about building shared culture of collaboration where clinical care and community support work together rather than separately. And finally, one of the most practical and impactful strategies is embedding a health coach within the clinical practice. Health coaches plays a critical role in chronic disease management. While physicians diagnose and prescribe treatment, health coaches often help patients translate medical advice into daily habits. They support patients in areas such as medication adherence, lifestyle changes, goal setting, and self-management skills. They also provide ongoing encouragement and follow-up, which helps patients stay engaged with their care plan over time. So by embedding a health coach within the healthcare team, the practice creates an additional layer of support that strengthens the entire CCM model. So when we look to all these steps together, we can see CCM program is really about building a system of collaboration. It starts with leadership, continues with shared information and patient identification, and grows through a strong partnership between healthcare providers and community organizations. And when all these pieces comes together, the result is a much more coordinated, proactive, and patient-centered approach to managing chronic diseases. Sorry. So the next step is to understand what really makes this process successful. Because the truth is chronic care management is not built on good intentional alone. It's need the right structure, the right systems, and the right partnership. And that's exactly what this slide highlights, the key factor that help CCM move from an idea into a safe, organized, and sustainable model of care. Let's begin with the business associate agreements. This is one of the most important foundational elements in any collaboration that involves patients' information. As we know, CCM depends heavily on coordination between providers, care teams, and sometimes community-based organizations. But once patients' information starts moving between different partners, confidentiality and legal responsibility becomes extremely important. So a business associate agreements, or BAA, helps define how protected health information can be shared, used, and safeguarded between the organizations. In simple words, it creates a formal and trusted framework for collaboration. And actually, without this type of agreements, the partnership may exist in theory, but it will struggle in practice because data sharing cannot happen safely or confidently. The next key factor is HIPAA, training for embedded personnel. So if we embed the staff such as health coaches, care coordinators, or community partners inside the clinical practice, they are no longer working at the edge of the system. They are now part of the care environment itself. And because of that, they must understand how to handle patient information responsibly and proficiently. So the BAA training ensures that these embedded personnel know how to protect privacy, maintain confidentiality, and follow the correct process when accessing or communicating patients' information. So this training is not just technical requirements, it's really about building trust, professionalism, and patient safety into the model from a very beginning. And closing related to that is BPA training for CBO staff who are supporting the project. Community-based organizations may play a major role in the chronic care management, as you know, especially when it becomes to health coaching, lifestyle support, self-management education, or social support services. But if these staff members are participating in the CCM projects that involve patient-level information, they also need to understand the standards of privacy, confidentiality expected in healthcare setting. So these trainings help align community staff with the clinical side of care. In other words, we can say it helps everyone involved speak the same language when it comes to patient protection, ethical practice, and responsible communication. And another essential factor is having a strong health IT system. As we know, chronic care management is continuous by nature. It involves follow-up, documentation, tracking progress, coordinating services, and often communicating across different team members. None of this can work efficiently without a reliable information system. A good health IT systems help teams document care plans, monitor patient progress, record intervention, and identify patients who need follow-up. And actually, this is what transforms CCM from a scheduled effort into organized workflow. So technology here is not just a support tool, it's really one of the operational backbones of the whole process. And once we have the health IT system, the next important issue is data exchange. Because collecting information is one thing, but being able to exchange it meaningfully between partners is something else. And CCM providers, care coordinators, and community organizations often need to know what has already been done, what the patient's needs next, and what changes have happened over time. So effective data exchange helps make care more connected. It reduces duplication, improves communication, and allows the team to respond more quickly and more accurately to patients' needs. And from a patient's perspective, this means they are less likely to experience fragmented care or feel like they are repeated the same story to different people again and again. Another very important factor is having bi-directional referral patterns. This means the referrals do not move in only one direction. It's not just provider sending the patient to a community service and then losing visibility. No, and instead there is a two-way relationship. The provider can refer a patient to the community partner, and the community partner can then send feedback, updates, or recommendations back to the provider. And this is a very powerful idea because it turns referral from a one-time transaction into an ongoing loop of collaboration. So rather than working in parallel, both sides stay connected around the patient's journey. And finally, one of the most important factors of all is the person-centered plan process. Because of the end, CCM is not just about systems, fragments, and workflows. It's about people, and it's about understanding the patients as a whole person, not only their diagnosis, but also their goals, preferences, daily challenges, and what matters most to them. A person-centered planning process means the care is built with the patients, not just for the patient. It means the care plan reflects real life. For example, it considers whether the patient can actually follow the treatment, whether they have transportation, whether they understand the plan, and whether the goals are meaningful to them. And actually, this is what makes CCM feel human. Because when care is personal-centered, patients are more likely to engage, trust the system, and stay connected to their care over time. So, if we bring all these factors together, we can see that successful chronic care management, or CCM, depends on much more than clinical knowledge alone. It depends on legal protection, staff preparation, secure system, strong communication, shared referral pathways, and most importantly, a care model that keeps the patient at the center. And that is what makes CCM both effective and sustainable. It's structured enough to work at the system level, but human enough to make a real difference in patients' life. There is another dimension that we cannot ignore, and that is the financial side of the model. Because for CCM programs to succeed and expand, they must not only improve patients' outcomes, but they also need to be financially sustainable for healthcare system and organization. So in this slides, we're gonna highlight some of the most important financial considerations when implementing a CCM program. Let's begin with the total number of eligible patients. One of the first questions any healthcare organizations ask before implementing a CCM program is how many patients is in our practice actually quality for this service. As we know, CCMs typically targets patients with 2 or more chronic conditions that requires ongoing management. So identifying the total eligible populations helps the organization estimate the patient scope of the program. It gives a clearer idea about expected workload, the resources needed, and also potential revenue that the program may generate. In other words, understanding the patient's populations help organization determines whether the CCM program will be operationally and financially viable. Another important aspects involve mutual expectations regarding referral volume. When providers collaborate with community-based organizations for care coordination teams, there needs to be a clear understanding of how many patients are expected to be referred into the program. This is important because both sides may be investing time, staff, and resources into supporting the CCM initiative. So having clear expectations about referral volume helps maintain balance in partnership. It ensures that the program operates smoothly and that both partners feel the collaboration is fair, productive, and worthwhile. Another key financial concept is break-even point. Simply put, the break-even point is the moment when the revenue generated by the CCM program becomes equal to the cost required to run it. At the beginning of the implementation, organizations may need to invest in staff training, IT system, care coordination, infrastructure, and workflow redesign. But over time, as more eligible patients enroll and services are delivered consistently, the program begins to generate revenue. So reaching the break-even point means that the programs has moved beyond the investment phase and has started to sustain itself financially. Another essential factor is the charge capture process. Even if a practice provides excellent work care management services, those services must be properly documented and billed in order for the organization to receive reimbursement. So the charge captures process ensures that all eligible CCM activities such as care coordination, patient communication, and care plan management are accurately recorded and submitted for billing. And without any effective charge capture system, organizations may actually provide valuable services but fail to receive the financial reimbursement by deserve. And closely connected to this, revenue cycle management. Revenue cycle management refers to the entire financial workflow of the healthcare services from documenting care to submitting care to receiving payment from payers. In the context of CCM, this means ensuring that services are properly coded, claims are submitted correctly, and reimbursement are tracked efficiently. A strong revenue cycle management system helps prevent delays, errors, or lost revenue. And ultimately, it ensures that the financial side of the program remains stable and sustainable. Finally, we have invoice timeline, and this refers to the schedule and process through which billings occurs and payment are received. In CCM programs, services are often billed on a monthly basis, depending on the amount of care coordination provided. So having a clear invoice timeline helps organizations among cash flow and maintain financial stability. It also ensures transparency between providers, partner organizations, and payers regarding when services are delivered and when payment are expected. So when we look to all these financial considerations together, we can see the successful CCM programs require not only strong clinical coordination, but also thoughtful financial planning. From identifying the right patient population to ensuring proper billing and revenue management, each of these elements play a role in making programs sustainable. And even when the clinical and financial side of CCM are aligned, healthcare organizations are better positioned to deliver continuous coordinated care for patients living with chronic conditions. So the next step is to make those expectations measurable. Because in any successful partnership, especially between providers or community-based organization, is not enough to state that we want the programs to work. We also need to define successful. We also need to design success looks like how we will measure it. and how both sides will stay aligned over time. And that is exactly what this slide is about, tracking performance by establishing mutual expectation, especially from the financial perspective. Let's begin with a number of alert clients. This is one of the most basic but also one of the most important performance indicators, because no matter how strong models is, its financial sustainability depends on how many eligible patients are actually enrolled in the program. In other words, enrollment tells us whether the program is truly reaching the population it was designed to serve. It also helps both partners understand whether referral efforts are working and whether the program is growing as expected. So this metric is not just a number, it's an early sign of whether the CCM model is gaining real traction in practice. And the next measure is the number of services provided by beneficiary per month. And this is very important because CCM is not simply about enrolling patients and leaving them in the system. It's about providing ongoing meaningful support over time. So this indicator helps us understand how actively each patient is being supported. For example, are they receiving regular follow-up? Are they getting coaching, care coordination, medication review, or help with self-management? And actually, this measure reflects the real intensity of care being delivered. So it gives a clearer picture of the program's actual activity level, not just its size. Another important metric is billing generated per coach. Since health coach for care coordinators often play a central role in delivering CCM services, it's helped to understand how much billable activity is being generated through their work. This does not mean reducing care to numbers alone. Rather, it helps organization assess productivity, workflow, and financial contribution of each care team member. So these measures can help identify whether staffing levels are appropriate, whether training is effective, and whether the program is being implemented efficiently. And closely related to that is aggregate billing per beneficiary per month. This measure looks at the overall billing generated for each patient is given a month. And this is useful because it's help organization understanding the financial value associated with each enrolled beneficiary, and it allows show and it also show whether the level of service being delivered is translating into appropriate reimbursement. So in the other way, we can say this metric connects clinical activity with financial performance on a per patient basis. Then we move to aggregate billing per population. While the previous metric focused on the individual beneficiary, this one looks at the bigger pictures. It shows a total billing generated across the entire enrolled population. And this is important because healthcare leaders often need to understand not just how one patient or one coach is performing, but how the whole CCM population is contributing to financial health of the program. So this metrics help is strategic planning, forecasting, and evaluating the overall scale of the initiative. Another important consideration is administrative fees. Is the administrative fees. So as we know, running a CCM program involves more than a direct patient interactions. There are also background cost, coordination, documentation, scheduling, communication, system building support, and program oversight. So administrative fees help account for the operational work that supports the program behind the scenes. And this is important because if those costs are ignored, the program may appear stronger financially than it actually is. So being clear about administrative fees helps create a more honest and realistic picture of financial performance. The next point is billing cycle. This refers to how often billing is proceeded and submitted. This is matter a lot because even if services are being delivered properly, delayed or inconsistent billing can affect cash flow and disrupt financial stability of the program. And a clear billing cycle helps all partners understand when services are documented, when claims are submitted, and when reimbursement should be expected. So this creates more predictability and supports better financial planning. And finally, we have the invoice timeline, and this is the time of invoicing and payment between the organization involvement. In collaborative CCM models, especially those involving community-based organizations, it is essential to know when invoices will be issued, how quickly they will be processed and when payment is expected. Because if this timeline is unclear, even a well-performing program can experience tension or confusion between partners. So having a clear invoice timeline strengthens trust, improves accountability, and helps keep the partnership running smoothly. So what we see is the tracking performance in CCM is really about creating clarity around how many patients are being served, how much care is being delivered, how revenue is being generated, and how financial responsibility are being shared. And that is why establishing mutual expectation is important, because when both partners agree in advance on what will be measured and how success will be tracked, the collaboration becomes more transparent, more stable, and much more sustainable over time. So let's now move to another very important part of tracking performance in chronic care management. And that is understanding the patient more deeply. Because the truth is, if we only track billing, enrollment, and revenue, we may know whether the program is running, but we will still may not know whether it's truly meeting the patient's needs. And that is why this slide is so important. It shows us that CCM establishing mutual expectation is not only about financial targets, it's also about identifying the right clinical indicators and the right patient's needs from the beginning. So in the other words, we need to know both what is happening medically and what is happening in the patient's real life. Let's start with the clinical indicators. These indicators help us understand the patient's health status more clearly and identify which individuals may need closer follow-up, more support, or more intensive coordination of the care. And actually, this is one of the strengths of the CCM. It encourages us to beyond the diagnosis code and really understand the patient's overall conditions. The first point is the primary diagnosis. This is important because patients' main diagnosis often shapes the overall care plan and determines the types of support they will need. For example, a patient whose main issue is heart failure may need close symptom monitoring, medication review, while patient with diabetes may need stronger support around self-management, nutrition, and lifestyle. So identifying the primary diagnosis helps the care team prioritize the right intervention from the very beginning. And within the clinical picture, depression status is especially important. As we know, depression can clinically affect how patient engages with care, as we discussed. And a patient with depression may struggle with motivation, attending appointment, taking medication regularly, or even participating in self-care. So, as we said, depression is if patient presented with depression and we do not recognize it, the whole care plan may look good on paper but fail in the real life. So that is why screening for depression and understanding its impact a very important part of effective CCM. Another important indicator is malnutrition. This may sometimes be overlooked, but it can have a major effect on outcomes, especially in older adults and patients with chronic illness. Malnutrition can weaken the patients physically, delay recovery, and worsen frailty, and increase the risk of hospitalization. So when CCM identifies malnutrition early, the team can respond with nutrition support, education, and referrals that make the care plan much more effective and realistic. Another very human and very practical indicator is the readiness for change. Because not every patient is at the same stage emotionally or psychologically. So some patients are ready to modify their diet, improve medication adherence, or engage in lifestyle changes. Others may still feel overwhelmed, resistant, or unsure. And this is matter a lot because in CCM, we are not only asking what should this patient do, we are asking, is this patient ready and able to do it right now? So understanding readiness for change helps the team provide support that is realistic, patient-centered, are more likely to be success. The next point is dual eligible status. And as we discussed, this is referred to the patients who equally qualify for both Medicare and Medicaid. And as we know, these patients often have more complex medical and social needs, and they may face financial barriers, higher diseases burden, or more difficultly navigating in the healthcare system. So identifying dual eligible status helps the care team recognizes that patient may require stronger coordination, more support services, and closer follow-up. Another important factor is Medicaid waiver enrollment or managed LTSS, which is stand for the long-term services and supports. So this is especially relevant for patients who need long-term help with daily functioning home-based support or extended care services. If a patient already connected to these systems, that gives the CCM team a better understanding of the services already in place. And if they are not connected but clearly need them, they may signal an important gap in care. So this indicator helps the team see the broader support structure around the patient, not just medical needs. But clinical indicators alone are not still enough because patients may have a clear diagnosis, as we say, and a clear risk profile, yet still struggle for reasons that are not purely medical. And this brings us to the second half of this slide, which is the patient needs. So this section is really where CCM becomes even more human, because here we move from asking what disease does the patient have to asking what kind of support does this person actually need in daily life. And that shift is very important. The first point is need for social services. Many patients with chronic disease do not struggle only because of their diagnosis. They may struggle because of transportations, as we said, financial instability, food insecurity, social isolation, or limited family support. So when CCM identifies a need for social services, it allows a care team to connect the patient with resources that directly affect their ability to stay healthy. And actually, this is one of the clearest example of why chronic care management must go beyond the clinic. And another important need is homebound status. Some patients are unable to leave home easily because of frailty, disability, advanced illness, or mobility limitation. And this changes everything about how care should be delivered. These patients may need home-based services, remote follow-up, or stronger care coordination to prevent them from becoming disconnected from the healthcare system. So identifying homebound status help the team adapt care to the patient's real circumstances rather than expecting the patients to fit into a standard model. The next point is OAA services, which is referred to the service under the Older Americans Act. These services often include support such as meals, caregivers assistance, transportations, and other community-based resources for older adults. And for many patients, these support are not extra, they are essential. Because when an older adult receives the right community support, they are much more likely to remain stable, independent, and engage in care. So recognizing the need for AAA is services help CCM connect medical care with aging support services in a very practical way. Another important consideration is veteran status. So may have access to specific programs benefits and support systems that can influence how care is coordinated. At the same time, some veterans may also have unique medical, psychological, or social needs that require additional attention. So recognize it, their status is important because it helps the care team understand what services are valuable, what services are available for them, and how care can be coordinated more effectively. And related to that, this VA choice and VDHCBS. This refers to veteran-related care programs, including options for receiving community-based care and veteran-directed home and community-based services. And in these simple terms, these programs give eligible veterans more flexibility and support in how they receive long-term care. So if a patient is eligible for these services, that can be significantly shape the care plan and create additional opportunities for support outside the traditional healthcare setting. So when we put all these points together, we can see something very important. In chronic care management, tracking performance is not just about measuring activity, it's about understanding patients from the two essential angles: their clinical conditions and their real life needs. Because if we only focus on medical indicators, we may miss the barriers that are preventing improvement. And if we only focus on social needs without understanding the clinical pictures, that the care plan may lose direction. But when both are considered together, the result is much more complete, realistic, and compassionate model of care. And this is exactly what the CCM is meant to achieve. We now come to one of the most important people in this model, the embedded health coach. Because as we know, CCM is not only about care plan, documentation, or referrals, it's also about having someone who can stay close to the patients, reinforce education, support behavior change, and help translate medical recommendations into everyday action. And that is exactly why the qualification of health coach matters so much. If this role is going to influence patient care, then it must be built on proper preparation, clear documentation, and the right training. Let's start with the first point, developing a personnel file for each coach. This may should administrative at first, but actually maybe sound as administrative at first, but actually it's a very important part of building a safe and professional CCM program. A personnel file helps ensure that every health coach has been properly reviewed, documented, and prepared before becoming part of the care team. In other words, it creates accountability. It shows that the coach is not just informally involved, but is formally recognized as someone working within the structured healthcare model. The first part of the file is the job descriptions and resume. This is important because the role of health coach must be clearly defined. What exactly are they expected to do? What are the limits of their role? And what background or experience do they bring to the team? The job descriptions gives a clarity to the organization, while the resume helps confirm that the individual has the appropriate background, communication skills, and readiness for the role. So these steps helps ensure that the right person is being placed in the right position. Next comes to the background check. Since health coaches may work closely with the patients, sometimes in sensitive situations or community settings, it's essential to confirm that they are appropriate and safe for this role. This is especially important in the model like the CCM, where trust is central. So patient needs to feel safe, and organizations need to feel confident that people representing the program are reliable and professionally suitable. Another key part is training. Even if someone is kind, motivated, and has a relevant background, they still need training to function effectively within CCM program, because health coaching in chronic care is not just about giving advice. It's about communication, follow-up, supporting self-management, understanding patient barriers, and working in coordination with wider care team. So training helps transform good intentions into structured and effective practice. Another essential element is the BAA and confidentiality statement. As we know, health coaches may have access to personal health information, care plans, and sensitive patient details. So it's extremely important that they understand confidentiality not only as policy but as a professional obligation. So understanding BAA or confidentiality statement reinforces the idea that protecting patients' privacy is not optional, it's a core part of the ethical care. And then we have TB testing, MMR, and flu requirements. These may seem like routine occupational health items, but they are actually very important when health coaches are embedded within clinical environments. If they are making around patients, especially older adults, immune-compromised individuals, or people with multiple chronic conditions, infection prevention becomes essential, as we know. So these requirements help protect both the patients and the staff member, and they reinforce the health coach is functioning as a part of the real health care settings, not outside of it. So these are functioning qualification and documentations requirements, but qualification alone not enough. If we want health coaches to truly add value to in CCM, they also need the right kind of training. So this brings us to the second major part of the slides, which is recommended training. And this section is especially important because it shows that health coaches are not only expected to be compliant, but also to be effective, skilled, and patient-centered in the way they work. The first recommended training is BAA. This is essential because health coaches must understand how to handle protected health information safely and correctly. They need to know what can be shared with whom, under what circumstances, and how to protect patient confidentiality in daily communication and communication. So training is really about making sure that trust is preserved at every step of the patient journey. The next training area is motivational reviewing, and honestly, this is one of the most powerful skills a health coach can have, because many patients with chronic diseases already know what they are supposed to do. They know they should eat better, exercise more, take medication regularly, and attend follow-ups. But knowing this not always the same as doing. And this is where motivation interviewing becomes so valuable. It helps the coach speaks with patients in a way that's supportive rather than judgmental, and collaborative rather than directive. And instead of telling patients what to do, it helps them explore their own motivation, readiness, and personal goals. And that makes behavior change much more realistic and much more human. Another important area is a disease self-management skills. Since chronic diseases are managed largely outside the clinic, patients need practical skills to live with their conditions every day. This may include understanding symptoms, taking medications correctly, monitoring morning signs, following diet plans, or knowing when they seek help. So health coaches needs to train it in supporting these self-management skills. Because the goal is not make patients dependent on the system. It's to make patients more confidential, informed, and capable in managing their own health. And finally, training in abuse, neglect, exploitations, and mandatory reporting. This is especially important because many CCM patients are older adults, social vulnerable, and or people living with significant functional limitations. In these populations, health coaches may sometimes be among the first people to notice warning signs of neglect, abuse, unsafe living conditions, or they need to know how to recognize these concerns and what steps must be taken when reporting is required. And actually, this is very powerful reminder that the health coach's role is not only to support disease management, they should also help protect patient safety and dignity. So, when we look to all these, we can see that an embedded health coach is much more than an assistant or support person. They are a structured, trained, and trusted part of the CCM model. Their role depends on proper screening, clear documentation, confidentiality, health and safety, preparation, and strong practical training. And when these elements are in place, the health coach becomes a powerful bridge between the clinical team and patients' daily life. And that is exactly what makes this role so valuable in CCM. As we know, patients with chronic diseases needs ongoing follow-up coordination, communication, scheduling, documentation, and billing. And CCM really depends on the strength of the entire practice team. So in these slides, we highlight the key practice personnel who makes the CCM model functioning smoothly in real life. In other words, if we want coordinated care for the patient, we also need coordinated work behind the scenes. Let's start with the practice manager. In many ways, the practice manager is one of the central operational leaders of the whole process. These persons help recognize the workflows, oversees staff responsibilities, solve logistical problems, and make sure that the CCM program is functioning in a structured and efficient way. And actually, even the best clinical model can struggle if the operational side is weak. So the practice manager plays a key role in turning the idea of CCM into something that actually works day to day. So they help create order, accountability, and consistency within the practice. Next, we have the front desk personnel. Sometimes this role may seem simple from the outside, but in reality, it's very important. From this desk, a front desk is often the first point of contact for the patient. So these team members help shape the patient's first experience with the practice, whether the experience feels organized, welcoming, and supportive, or confusing and discontinued. So in the context of the CCM, front desk staff may help identify patients, confirm appointments, and communicate basic information, and make sure patients stay connected to the stay system. Sorry, let me just try it. We can be finished. I'm sorry. So these teams members will gonna help patients first experience with practice, whether the experience feel organized, welcoming, and supportive, or confusing and disconnected. In the context of the CCM, front desk staff may help identify patients, confirm appointments, communicate basic information, and make sure patients stay connected to the system. So even though they may not be delivering clinical care directly, but they play a very important role in maintaining continuity and patient engagement. And then we have the scheduler. As we know, chronic care management depends heavily on timing and continuity. Patients may need follow-up visits, care coordination calls, health coaching sessions, or referral to other services. If scheduling is not well managed, patients can easily miss important steps in their care journey. So the schedulers helps keep the entire system moving. They make sure the right patient connects with the right service at the same time. This may sound administrative, but in reality, it has a direct impact on the care quality and patient adherence. Another very important role is the practice care coordinator. This is often one of the most visible and active roles within CCM. The care coordinators helps connect all the different parts of the patient's care, the provider, the patient, the family, community resources, and sometimes multiple specialists And because many patients with chronic conditions are dealing with complex treatment plans, multiple medications, and several appointments, this coordination becomes essential. So the care coordinators helps reduce fragmentations and improve communication, and also make sure important details do not get lost between different parts of the system. And in many ways, this role helps hold the whole care journey together. And finally, we have the billing staff. This role is extremely important because no matter how well the care is delivered, the program must still be documented and billed correctly in order to remain sustainable. Billing staff help ensure that CCM services are captured accurately, coded appropriately, and submitted correctly for reimbursement. Without strong billing support, and even a successful care model may struggle financially. So this role helps connect the clinical value of the program with its financial sustainability. And that is essential because CCM to continue helping patients over time must also remain operationally and financially viable. So when we look to all these points, one message became very clear. Chronic care management truly a team-based model. It depends on leadership, communication, coordination, patient flow, and financial flow through. And every member of the practice contributes in a different way, but all those contributes are connected, and that is makes CCM to be strong. And it's not about just clinician doing more work. It's about whole practice working together to provide more continuous organized care. So moving to the next slide, the next questions becomes what does the health coach actually do in day-to-day practice? And actually, one of the most important parts of the role begins even before meeting the patients, because effective care management do not start at the moment of appointment only. It starts with preparation. It starts with knowing who is coming, why they are coming, what their coverage looks like, and whether these visits may create an opportunity for support, follow-up, or enrollment. And this exactly in this slide, what we will discuss, the prep routine of the health coach. Let's start with the first step, reviewing the schedule for the week. This may sound simple, but it's actually a very strategic part of this process. When the health coach reviews the weekly schedule in advance, they are not just looking at the name and appointments time. No, they are looking for patterns, opportunities, and patients who may benefit from additional support. Or we can say, in other words, this step helps the coach move from being reactive to being proactive. And instead of waiting for issues to appear during the visits, the coach starts planning ahead. One important part of this review is understanding the appointment reason, because the reason for the visit can tell us a lot about what the patients may need. For example, is this a routine follow-up, a post-hospital visit, a medication check, a worsening chronic condition? And each of these reasons may signal a different level of risk, need, or opportunity for intervention. So by reviewing the appointment reason early, the health coach can better anticipate which patients may need closer coordination, more education, or possible CCM enrollment. And along with the appointment reason, payer or insurance status is also very important. As we know, eligibility for different services often depends on the patient's insurance coverage. So the health coach needs to understand whether the patient's payer supports CCM related services, what resources may be available, and whether there are financial or administrative factors that could affect care planning. So this makes the process more efficient and avoided confusion later. So in a way, reviewing insurance status helps align clinical opportunity with practical feasibility. The same applies to co-insurance information such as Medicaid, AARP, or UHC, and similar plans. This matters because some patients may have additional coverage that affects eligibility, benefits, or out-of-pocket costs. And if the coach understands this in advance, they can approach patients more clearly and more confidentially. And this also will help the practice avoid delays and makes the enrollment process smoother. So this is not just administrative, it's part of creating a more informed and patient-centered workflow. But of course, schedules are never completely fixed. And that is why another important part of prep routine is to assess the schedule daily for changes. So patients cancel, appointment move, urgent cases get added, or priority shifts. So the health coach needs to stay flexible. This daily review helps make sure the coach is always working with the most current information rather than relying um, on the original weekly plan. And that flexibility is very important in real life practice because chronic care management must adapt to what is actually happening, not just what expected to happen. Another key step is the coordinating with the practice care coordinator to target patients based on the schedule. So this is where the teamwork became very visible. The health coach is not working alone and identification of potential CCM patient is not based on guesswork. So instead, the coach and the care coordinators work together to look at the schedule and identify which patients may need additional support, which patients may meet eligibility criteria, and which visits create opportunities for outreach or enrollment. And this is steps will gonna help transform the schedule from a passive list of appointment into an active tool for appointment targeting and care planning. We're gonna help in transform the schedule from passive list of appointment into an active tool for patient targeting and care planning. So, and finally, the coach reports the daily list of potential clients to enroll. This is important closing step in the prep uh, process because it turns observations into action. So after reviewing the schedule, checking the visit type, understanding insurance, and coordinating with the care team, the health coach then can create a list of patients who may appropriate candidates for CCM enrollment. This helps the whole team stay aligned. It ensures that opportunities are not missed and it creates a more organized and systemic approach to growing the program. So rather than relying on the chance, the practice develops a daily rhythm of identifying and engaging the right patients. So, above all, we can see that preparation routine of the health coach is really about readiness. It's about being informed and being organized and being one step ahead. And the coach reviews the schedule, understands the reason for the visit, check coverage details, adapts to daily changes, and coordinate with the care team, and identifies patients who may benefit from the enrollment. And that is exactly what will gonna make the role of CCM valuable. And because CCM better care does not begin by chance, it will gonna begin with the thoughtful preparation. So next is what actually happens during the day when patients arrive at the clinic. Because as we know, like even so, if we prepared, preparation is not alone enough. So the real impact of the chronic care management happens during these daily interactions when the health coach meets the patients, introduce the program, and begins building engagement. So in this slide, we will gonna discuss the daily operation routine of the health coach inside the practice. The first step is coordinating with the front desk to greet clients before they see their providers. And this step is actually very strategic, as we said, like because when patients is arrived and they are often focused on their upcoming medical visits and maybe not be expecting additional service or conversations. So the front desk and the health coach work together to create a smooth introduction, and the front desk may notify the coach that a potential CCM candidate has arrived, and this gives the coach the opportunity to briefly connect with the patients before the provider appointment. And these early interactions helps make the conversation feel natural rather than unexpected. Once the initial contact is made, the next step is introducing the program. And interestingly, this introduction is usually done using a defined script. So now this does not mean the conversations becomes robotic. Rather, the scripts helps ensure that every patient receives clear, consistent information about the program. It also helps avoid confusion or miscommunication, and the scripts is usually developed and agreed upon by practice administrator and community-based organizations involved in the program. So the goal here is consistency, making sure patient understanding what the program is, what the support is offers, what and how it may benefit from them. But of course, introducing program is only the first step, and the next step is assessing whether the patient is actually willing to participate. And this part requires good communication skills, as we know. The health coach needed to listen carefully, understand the patient's perspective, and gauge whether they feel ready to engage in additional care support. Some patients may be very interested because they feel they need help managing their conditions. Others, they may hesitate because they are unsure about time, commitment, or additional services. So the coach's role here is not to pressure the patients, but rather to explore their readiness and answer their questions. And this is a step is about building trust. And if the patient shows interest, the next step is supporting the development of person-centered care plan. And this is a very important concept in modern healthcare. Instead of creating a plan that only focuses on clinical targets, the goal is understanding the patient's individual needs, priorities, and life contexts. For example, what challenges do they face in managing their condition? What goals matter most to them? What barriers may affect their ability to follow treatment recommendations? The health coach helps gather these information and supports the provider in shaping a plan that reflects the patient's real situation. So the care plan becomes something built with the patients, not just for the patient. Another important step is obtaining endorsement from the provider. As we know, patients often place a high level of trust in their physician or primary provider. So when the provider supports the program and encourages the patient to participate, the endorsement can significantly increase patients' engagement. It reinforces the message that this program is not separate from their model care. It's actually part of their care team. So provider support strengthens the credibility of the program. And finally, once the patient agrees to participate, proper documentations becomes essential because CCM must flow clear, regular, and billing requirements, as we said. So the health code documentation key elements such as the person-centered care plan and patient's verbal consent to participate in the program, which is very important. This documentation ensures that the care process is transparent, compliant, and properly integrated into the patient's medical record. It also supports continuity so the every member of the care team understands the patient's goals and engagement status. So the next important questions becomes what exactly goes into person-centered care plan. Because in CCM, we are not just tracking diseases, we are supporting people. And that means care plan must reflect patients' medical conditions, their social situation, their emotional well-being, and even their cultural background. So this slide we're gonna highlight the key elements, the shape, and truly person-centered care plan. First of all, person-centered care plan is designed to span a full 12 months. And this is very important because chronic diseases do not change overnight. Managing conditions like diabetes, heart disease, or depression requires continuous support, monitoring, or adjustment over time, as we know. So instead of focusing only on a single visit or for a short intervention, the care plan provides a structured framework for the entire year. So it allows the care team to track progress, reassess goals, and adapt intervention as the patient situations evolve. In other words, plan support continuity of care rather than isolated encounters. Now, when we talk about patients' needs, we are really looking at the three interconnected points. First, of course, there are medical needs. This includes the patient's diagnosis, medication engagement, disease monitoring, and preventive care requirements. But medical needs alone do not tell the full story. Many patients also face social challenges such as financial limitations, as we see, transportation difficulties, food insecurities, or limited access to healthcare services. And then there is a psychosocial dimension, which includes mental health, emotional well-being, social isolations, and the patient's coping capacity. So when these three aspects are considered together, the care plan becomes much more realistic and effective. And because managing chronic disease needs supporting the person living with that disease. So once the patient's needs are clearly understood, the next step is designing appropriate intervention. So these interventions are actions that helps translate the care into meaningful outcomes, and several key strategies are typically included. One important intervention is ensuring that preventive health appointments are appropriately, and preventive care plays a major role in chronic disease management, as we know. So regular screening, follow-up visits, and monitoring appointments help detect complication early and maintain disease control. So the care plan often includes a clear schedule for preventive visits to keep patients engaged with the healthcare system. Another important component is participations in evidence-based programs. These are programs that have been significantly proven to improve patients' outcomes. Examples may include chronic disease self-management programs, diabetes education, or lifestyle modification programs. And by integrating these programs into care plan, the healthcare team ensures that interventions are not based on the guesswork but on proven strategies, which is very important. And of course, individual health coaching plays a central role. Health coaching provides personalized guidance that helps patients understand their conditions, build healthier habits, and stay motivated throughout their care journey. Unlike brief clinical visits, coaching offers ongoing support and accountability. It allows patients to ask questions, discuss challenges, and gradually build confidence in managing their health. So this personal connection is often that makes long-term behavior change possible. Another key element to consider is cultural factors that may influence health behaviors and healthcare decisions. Culture can shape how patients perceive illness, how they communicate with providers, and how they approach treatment. For example, beliefs about diet, family rules, traditional medicines, or stigma around mental health can also influence patient choices. So, by acknowledging and respecting these cultural factors, the care team can design interventions that are more acceptable and more effective for the patients. Finally, we must consider the broader social determinants of the health. These include factors such as housing stability, education, income level, transportation access, and community resources. And research consistently shows that these social conditions can have powerful impact on health outcomes. So addressing these determinants can involve connecting patients with community resources, social services, or support programs. And in many cases, improving these social conditions can be just as important as adjusting medication. So, if we look to all of these elements, we can see the person-centered care plan is much more than a clinical document. It's a comprehensive roadmap that considers patients' medical needs, social context, emotional well-being, cultural background, and long-term goals. And by integrating all this, the care team can deliver support that is not only medically appropriate, but also a realistic, sustainable for the patient.
Are you finished, Dr. Malaz?
No, sorry.
Okay, go on.
Right. So, as we know, because of the CCM, success is not about providing service, it's also about measuring progress, understanding outcomes, and continuously improving the program. So this step of daily routine focuses on reviewing performance, tracking enrollment, and documenting the two quality indicators. The third step is recording the number of patients who were actually enrolled compared with those who were potentially eligible. This comparison helps the team understand how effectively the program is identifying and engaging the right patients. For examples, if many patients meet eligibility criteria but only a few enroll, that may suggest a barrier such as communication challenges, lack of awareness, or patient hesitations. On the other hand, if enrollment numbers closely match the eligible population, that indicates the outreach and engagement process is working effectively. So this metric helps the team evaluate the gap between opportunity and actual participation. Next, the health coach compares the day's enrollment numbers with the daily enrollment target or quota. So many care management programs operate with specific enrollment goals to ensure sustainability and proper utilization of resources. By reviewing these targets daily, the coach and the practice team can assess whether the program is growing as expected. If enrollment is lower than expected, the team can reflect on possible reasons and adjust their approach. For example, they may refine patient education, improve coordination with provider, or adjust how the program is introduced. And this process encourages continuous improvement rather than waiting until the end of the month to evaluate performance. Beyond enrollment numbers, the program also tracks important financial and clinical quality measures. These measures helps ensure that the program is not only financially sustainable, but also clinically meaningful. In other words, the goal is not simply to enroll patients, but to ensure that the right patients are receiving the right level of care support. And one of the key indicators recorded is the patient's primary diagnosis. This information helps the care team understand which chronic diseases are most commonly represented within the program. It also allows the program to tailor interventions and education resources to the conditions most frequently managed. Depression status is another important measure. So, as we know, the mental plays a major role in the chronic disease. So, uh, tracking depression status by tracking depression status, the care team can ensure that psychological needs are recognized and addressed as part of the overall care strategies. And another indicator is a dual eligible status, meaning patients who qualify for both Medicare and Medicaid. So these patients often have more complex healthcare needs and may require additional coordination between different healthcare and social support systems. And identifying these groups will gonna help ensure that the program can connect them with appropriate resources and support services. And veteran status is also documented, so they may have access to additional support system such as services provided through the Afris healthcare network, and recognizes this status allows the care team to coordinate care more effectively and connect patients with resources available to them. Another key factor coordinated is the social service needs. So many patients living with chronic conditions who's actually have challenges with housing instability, food insecurity, and transportation barriers. By documentation their needs, the care team can connect those patients with community resources that address these underlying factors affecting their health. Zip code or place of residence is also tracked. These informations help identify geographic patterns in healthcare needs and may highlight communities that face higher health risk or limited access to care. It also allows practice to collaborate with local community programs and public health initiatives. And finally, the program records whether the patient is enrolled in Medicaid waiver programs or managed long-term services and supports. And these programs often provide additional long-term sources for the patients with significant health or the functional needs. So tracking these informations will gonna help ensure that patients are receiving the full range of services available to support their health and independence. So above all, the health coach reviews enrollment performance, compares it with program targets, and record important clinically and social indicators. And this information, it helps the practice continuously refine the program and ensures that care management remains effective and coordinated well. But actually, behind the scenes, there is another very important rule that keeps the entire program functioning effectively, and that role belongs to the CBO administrator. So the community-based organization administrator is responsible for monitoring performance, identifying challenges, and ensuring that the program continues to reach the right patients and deliver meaningful support. So let us see the key administrative responsibility that helps sustain the program. First, the responsibility is assessing on a daily basis whether enrollment goals are being met. So, as we discussed earlier, CCM programs are often operate with defined enrollment targets. So, these targets are important not only for financial sustainability, but also for ensuring the program is reaching the population it was designed to support. So, by reviewing the enrollment program daily, the administrator can quickly identify whether the program can track or whether the adjustment may be needed. So this continuous monitoring helps keep the program proactive rather than reactive. And however, simply tracking numbers is not enough. And when the enrollment is lower than expected, the administrator also works to identify the barriers preventing patients from joining the program. And these barriers either limited patients awareness or time constraints during the clinic visits, or administrative challenges, or even concerns about additional services. Once these challenges are identified, the administrator discuss them with the practice manager so that the team can develop practical solution. And these collaborations ensure that the program keeps improving rather than repeating the same obstacles. Another key task is assessing the demographic of the population that has been enrolled. So the purpose here is to determine whether the program is actually reaching its intended target population or not. For example, if the program was designed to support older adults with chronic conditions that administrators need to verify, those patients are indeed the ones being enrolled. Looking at demographics such as age, socioeconomic status, or geographic location can help reveal whether certain groups are underrepresented. So this analysis will help to ensure the program remains equitable and aligned with the original goals. In addition to enrollment monitoring, the administrator also evaluates the services provided to each beneficiary on a monthly basis. So this step helps confirm the enrolled patient are actually receiving the support and follow up the program's promises. For example, are patients receiving regular coaching sessions? Are care plan being updated? are follow-ups and referrals being completed. So monitoring these services will help in enrollment translates into real care delivery rather than just administrative numbers. Finally, the administrator monitors participations in the different programs offered by the CBO itself. So these programs often extend beyond clinical care and provide additional community-based support for patients. So evidence-based programs are structured interventions that have been significantly validated to improve patients' outcomes. Examples may include chronic disease, self-management workshops, nutrition programs, or fall prevention programs for older adults. And encouraging patients to participate in these programs, as we know, can significantly enhance the effectiveness of care management. Another important category includes services provided under the Older American Act, OAA. So these services are designed to support older adults by promoting independence, health, and well-being. And they may including meal programs, caregiver support, transportation services, or well activities. And senior center programs also play a valuable role in supporting patients. And these centers often provide social activities, health education sessions, and opportunities for community engagement. And for many older adults programs, these programs help in reduce the social isolation and improve overall quality of life. And finally, social service programs address the broader social needs that may affect health outcomes. And these programs may help patients access housing assistance, food support, transportation, financial counseling. Addressing these social determinants can significantly improve the patient's ability to manage chronic conditions. So, above all, we can that focuses on the oversight, coordination, and continuations improvements. So while the health coaches works directly with patients, the administrator ensures that the program is functioning effectively at the system level. They monitor enrollment, identify barriers, analyze demographics, and review service delivery, and track participation in community programs. And this will gonna help ensure that program remains sustainable, targeted, and impactful for the population it serves. And another important dimension comes into focus, and that is billing and financial monitoring. Because for any care management program to be sustainable, it's need not only to improve patients' outcomes, but also to function within a viable financial structure. And monitoring billing allows the organization to understand whether the services being delivered are appropriately captured and aligned with the program cost. So first element is billing per beneficiary, and this refers to the amount of revenue generated for the each patient enrolled, as we see it. So tracking billing in this way is we're gonna help in we're gonna let the billing per beneficiary becomes an indicator of both services utilization and program efficiently. And beyond individual patients, the program also monitors aggregate billing across all enrolled beneficiaries, and this provides a broader view of a financial performance of the entire program. And by looking at the total revenue generated through the care management services, administrators can evaluate whether the program is financially suitable and capable of supporting staffing, training, and operational costs. And this aggregates perspective helps leadership make strategic decisions about program growth and resources allocation. And of course, revenue alone does not fool the story. So that is why billing must also be compared to program costs. And these comparisons will gonna help maintain financial balance while still prioritizing the healthcare. And another important step is reconciled billing. So reconciliation ensures that all billing services accurately match documentation and services that were actually delivered. So this process helps prevent billing errors, improve transparency, and ensures compliance with healthcare regulation. And in other words, reconciliations safeguarded both accuracy and accountability. And next, the program monitors the revenue cycle timeline. So revenue cycle refers to the entire process from providing healthcare services to receiving the payment for that service. So this includes documentation, billing submissions, payer processing, and reimbursement. And when there is any delay identified early, administrators can address them and maintaining steady financial flow for the program. Another key metric is tracking daily enrollments. So enrollment numbers directly influence the program financial and clinical impact. So monitoring enrollments daily also helps the team evaluate whether the outreach strategies are working effectively. And finally, the program evaluates productivity of the embedded health coach in relation to the enrollment numbers. So the health coach plays a central role in identifying eligible patients, introducing program, and support enrollment. So ultimately, this metric links workforce to performance with program growth and impact. So when we look to all these billing metrics, we can see that financial monitoring plays a crucial role in the sustaining chronic care management programs. And this balance between the clinical care and financial sustainability is what allows the CCB to continue supporting patients over the long time. So the next step is to see how the plan is actually translated into practical 12-month service model. And because of CCB, a care plan is not meant to stay on paper. It means to guide real actions over time. And that is exactly what this slide shows us, is how 12-month CCM service plan supports the patients through assessment, prevention, coordination, and continuous follow-up. Let's begin with one of the most valuable part of this service plan is in the home assessment to determine the risk. And actually, this is such as important step because many of the risk affect patients with chronic conditions are not always visible in the clinic. A patient may appear stable during an appointment, but once they return home, the real challenges become much clearer. So that is why home assessment matters. It allows the care team to understand the patient's environment, daily habits, safety concerns, and practical barriers in a much more realistic way. So rather than us assuming what patient's situations looks like, the team is able to see it directly. One important part of the home assessment is evaluating fall risk. So as we know, especially in elder adults and patients with chronic disease, falls can lead to major complications, including fractures, hospitalizations, loss of independence, and even long-term decline. And many fall risks are environmental, so they may related to loose RX, poor lighting, or unsafe bathroom steps, setups, cultural pathways, or mobility limitations within the home. So by assessing the for falls early, the care team can identify preventable hazards and recommended changes that improve safety and preserve independence. And that is very practical important of how CCM moves from treatment to prevention. And another essential part of the home assessment is reviewing the medications and documentations that finding. This is a very important because the medications management is chronic disease is often complex. Many patients take multiple prescriptions, and sometimes they also take additional products that may not appear in the formal medical records. So the same visit creates an opportunity to look at what the patient is actually taking, how they are taking it, and whether they are be risk that need to be addressed. And that OTC, that indicates over-the-counter medications. Patients often use OTC medications on their own, sometimes as assuming they are harmless because they do not require prescriptions, but in reality, these medications can still cause side effects, drug interaction, or duplications with prescribed treatment. So reviewing OTC use is important for getting a full and accurate pictures of the patient's medication burden. The same applies to herbal medications. Many patients use herbal or traditional remedies, and sometimes they do not mention them unless especially asked. But these products can also interact with prescribed medications or affect disease control. So this part of assessment is not about judging the patient's choices. It's about understanding the full reality of what the patient is using so that care can be safe and informed. And of course, another key issue is adherence to the prescribed medication regimen. So because even the best treatment plan cannot work if the patient is unstable in unable to flow it consistently. Sometimes non-adherence is related to forgetfulness. So sometimes it's related to cost, side effects, confusion, how health literacy, or simply being overwhelmed by too many medication. So this review helps the care team understand not only what was prescribed, but whether the patient is actually able to follow it in daily life. And this is where the real CCM becomes more human and practical. Another important component of the 12 months plan is enrollment in a scheduled evidence-based program. These are programs that have already been shown to improve outcomes through the structured education and support. For example, they may include chronic disease self-management programs, diabetes education, nutrition, or fall prevention programs. And this is important because CCM is not meant to rely on the individual visits. It's also connect patients to proven interventions that reinforce behavior change and self-management overall. So next part of the preventive health appointment schedule. As we know, the prevention is a major part of healthcare major part of good chronic disease management. So patients need routine follow-up, screening, as we know, and timely review to prevent deterioration and detect problems early. So the 12-month plans include a structured schedule for preventive health appointment. So this keeps the patient connected to care and reduce the risk of the gaps in the follow-up. And finally, coordinations with specialists in another key element of the plan. Many patients with chronic conditions are not being managed by one provider alone. They may be seen by cardiologists, multidisciplinary team, as we said. So, according to their needs. So without coordination, care can quickly become fragmented, and patients may receive multiple instructions, overlapping medications, or disconnected treatment plans. So CCM Health brings all of that together. So that means 12 monthly CCM, it's a plan which is serves for the structured roadmap for safer, more coordinated, and more proactive care. Let's look to the one of its most important, most powerful components is evidence-based program, because in we connected patient to interventions that that have already been shown to make real differences, and that is exactly why the evidence-based programs are such as important in CCM model. They added structure, consistency, and proven benefit to the care plan. Let's begin with the first point. The person-centered plan should support the patient in completing all applicable evidence programs. And actually, this is a very important idea, because a care plan should not only identify what patients need, it should guide the patient toward a specific program that can help meet those needs. So, for example, if patient has diabetes, balance problems, depression, or difficulty managing chronic illness, they may already be well-designed programs that address these issues directly. So the role here is not just list the problem, we have to connect the patient to meaningful solutions. So identifying the right program is the one thing, but helping the patients actually complete it's another. And this is whether the health coaching model becomes very important. And as we know, the many patients start programs with good intentions, but over the time, they lose motivations or face transportation barriers, or forget appointments, or feel overwhelmed. So the health coach is gonna help them stay engaged with this plan. And the final point on this slide is also very important, because it's focusing on documentations. Participation in these evidence programs must be documented for each individual patients on a monthly basis, as we said. So as we know, in the CCM, the patient is always followed as an individual. So even when the support is delivered in a group setting, the team is still need to know, did this specific patient attend? Is this, they participate? Are they progressing? Are there any barriers affecting their engagement? So documentations is very important. So overall, that evidence-based programs are not potential extras in CCM. They are a part of structured support that will gonna help the patient to build the skills and improve the self-management and stay engaged over the time. As we know, reality chronic illnesses does not affect only the body, so also affect how patients think, feel, and cope with their daily lives. So that's exactly why behavioral health integrations become such as important part of the modern care models. Let's begin with the first point. CCM services and behavioral integration services can actually be provided and billed for the same point patients within the same month. So this is important because it reflects a shift in how healthcare systems are approaching chronic disease management. For example, a patient may be receiving CCM support for diabetes management while also receiving behavioral health support for depression or anxiety. And the next questions became who is eligible for behavioral health integration services, which is very important. The eligibility criteria are intentionally broad because behavioral health challenges are extremely common among patients with chronic illnesses. First, eligibility includes any behavioral health condition. This may involve depression, anxiety, adjustment disorders, substance use challenges, or other psychological conditions that affect the patient's ability to manage their health. And behavioral health conditions are often influence motivation, decision making, and daily habits. In fact, according to the World Health Organization, depression is one of the leading causes of disability worldwide. So this statistic reminds us that mental health is not a minor issue or is isolated concern. It has profound impact on quality of life, productivity, and overall health outcomes. Another important point is that depression frequently occurs alongside chronic medical conditions. For example, depression is common comorbidity in patients with diabetes and cardiovascular disease. When these conditions occur together, they create a cycle that worsens health outcomes. Finally, although these services can occur in the same month, each intervention must still be documented separately. Proper documentation ensures that each service, whether it's chronic care management or behavioral health support, is clearly recorded, justified, and compliant with healthcare regulation. So, above all, the patients are not divided into the physical health problems and mental health problems. They experience both simultaneously. So what does this models add to the practice itself? Because of any healthcare model to be sustainable, it should not only benefit the patient, it should also create a real value for the practice delivering in the care. So, and actually, this is one of the strengths of the CCM. It will support better follow-up and more continuity, and at the same time, it creates practical and financial value for the healthcare provider. So let's begin with adherence to the medical office visits and prevention schedule. So CCM, it helps improve the connection through regular outreach, reminders, coaching, and care coordination, and patients are more likely to attend visits they actually need. And for example, the model may support multiple preventive health visits per year in addition to sick visits when needed. And this will create a more structured patterns of care. And another important example is the annual wellness visit. So this visit is especially valuable because it's create a dedicated space for prevention, risk assessment, and long-term care planning. And this is exactly where the health coach adds another layer of value. The health coach can actively support the completions of annual wellness visits by helping identify eligibility patients, reminding them, preparing them, and encouraging follow through. Another value-added benefit is CCM support of the telehealth services. And as we know, not all patients can easily attend in-person visits. Some face transportations, barriers, mobility, and so on. So telehealth becomes a very practical extension of the healthcare management, of the chronic care management, sorry. So the geographic restrictions for telehealth may be lifted for a certain beneficiary group. And this is important because it reflects a broader shift in healthcare delivery. It means that under some value-based care arrangements, patients can access telehealth support more easily without being limited by other geographic barriers. And one of these groups include participants in bundled payment programs during the episode of care. And this is significant because bundled payment models depend heavily on coordination, prevention, and efficient use of resources. The same idea applies to the patients in a next generation ACO. Since ACO model focus on quality, coordination, and cost control, telehealth becomes a useful tool for maintaining regular contact and improving outcomes without always requiring in-person visits. So, above all, CCM improves preventive follow-up, supports annual well visits, and strengthens patients' engagement and extends the use of the telehealth. So, this slide is broadening the perspective. So, until now, we have mainly been discussing CCM at the level of patients and the practice, but here we started to see how CCM fits within the wider healthcare financial models across the systems, and one of the most important of these models is bundled payment model. So first, bundled payment model supports value-based care models, and this is a very important concept. And in traditionally fee-for-service systems, providers are often paid for each individual service separately. But in value-based models, the focus shifts towards outcomes, coordination, and overall efficiently. So bundled payments reflect that shift. Another major advantage is that bundled payment programs encourage coordination between providers. And as we know, patients with chronic diseases often moves across multiple parts of the healthcare system. They may see primary care physicians, specialists, hospitals, team, rehabilitation services, and community-based support. And even so, without coordination, this can easily become fragmented and costly. And the final point is that many regions already participate in bundle payment initiatives through CMS programs. And this tells us something important. This is not just a theoretical concept. The model is already implemented across many healthcare settings. So for practice, for practices and systems thinking about CCM, we should move towards coordinations and value-based care.
Dr. Malaz,
Yes.
are you finished?
No.
Okay, we are waiting.
Okay, so we have in CCM, CCM service actually be structured and delivered in the real world through the models. So we have three models. First model is a clinical integrations with one individual Medicare providers. So let's start with the model number one. This model is based on clinical integration with an individual Medicare provider. And actually, this is often the most straightforward or most accessible starting point. In this model, the CCM service is built around collaborations with a single Medicare providers who is already established and able to deliver or bill for services. So rather than building a large system immediately, the organization begins with one provider relationship and integrates the chronic care support around the practice. And why is this useful? Because it allows the program to start on a smaller scale. It can easier to coordinate workflows, test processes, build trust, and understand the real operational needs of the model before expanding further. So this model is often good options for organizations that wanted to pilot CCM in a more focused and manageable way. So in a sense, it's a low barrier entry model, so it's smaller in scope, but very useful for building experience and providing providing value. Model number two is a broader and more scalable. Here, the idea is to contract with an organization that can already build Medicare and can support multiple providers across markets. So instead of working with just one physicians or a small practice, this model creates structured. This model creates a structure that can service several providers at the same time. And this is a very important because once CCM proves its value, many organizations begin thinking beyond individual practices and start asking, how can we support multiple clinics, multiple providers, or even broader regional network? And this model helps answer the questions. It creates a centralized structure for billing and operational support while still allowing services provider to benefit from the CCM program. That means more reach, more consistency, and more efficiency. So because rather than each provider trying to build everything independently, there is one organization that supports the process across the market. So this model is especially useful when the goal is expansion. It allows the program to move from a single provider arrangement to a more organized and market level delivery model. And model 3 is the most advanced and most independent model. This is approach organizations because a direct Medicare provider itself with appropriate infrastructure to deliver chronic care management services. And now this is a much bigger step because it means the organization is no longer depending on uh, another provider or another billing entity to operate the model. Instead, it develops its own structure, system, and regulatory readiness to function directly with the Medicare framework. And that has major advantages. It allows for greater control over the service delivery, billing process, staffing documentation, system and long-term program development, and it also gives the organization more strategic flexibility because it can design and manage CCM more directly. But at the same time, this model also requires the most preparation. It needs right infrastructure, administrative system, compliance rate, fit for organizations that are more better resources and ready to make to take a full together. If we compare all these model together, so we can actually see a kind of progression around one Medicare provider. And the second model is more scalable, supporting multiple providers through one billing scalable organization. And the third model is the most independent, where the organizations itself becomes a direct Medicare provider. So these are not just the three separate options. They can also be as three different levels of the organization readiness and strategic ambition. So some organizations may begin with model 1, grow into model 2, and eventually move towards model 3 as their capacity expands. And this is why contract models matter so much in CCM, because CCM is not only about identifying patients, creating a care plan, or improving outcomes. It also depends on having right structure of these services to make these services operational, valuable, and sustainable. And a strong clinical model without the right contract structure may target to survive, may struggle to survive. But when the care model and the contract model are aligned, the program becomes much more realistic and much more sustainable. So different organization may, I'm sorry, I'm talking about all of them together. So different organizations may choose different models depending on these size, goals, infrastructure, and even level of readiness. And what's matter is most is choosing a structure that allows programs to function effectively, grow responsibly, and continuing delivering, coordinating for patients living with chronic conditions. So we come to the end of this discussion. It's helpful to step back and look at the bigger picture of the CCM. And through these presentations, we explored how CCM is not simply a clinical intervention, but rather a structured system designed to support patients with chronic conditions through coordinated, continuous, and proactive care. And what becomes clear is the successful CCM program is not happened by chance. They follow a series of deliberate steps. First, we start by understanding the different CCM contract models. As we said earlier, there is no single pathway for implementing CCM, and a different organization may choose different contract structures depending on their partnership resources and operation readiness. And each model comes with their own financial strategies, responsibilities, and the level of independence. So understanding this option is the first step toward building a program that is both realistic and sustainable. And the second, once these models are understood, the step is choosing the right one. And this decision is not only about opportunity, it's about the capacity. Our organizations need to evaluate their available resources, infrastructure, staffing, and operational readiness. At the same time, financial readiness and risk tolerance must also be considered. In other words, the goal is to select a model that aligns with organization capabilities while still allowing room for growth. After selecting the appropriate model, the next critical step is building infrastructure that supports the program. CCM requires well-defined clinical workflows, reliable information system, and a strong care coordination process. And technology integrations becomes especially important here because documentation, communication, and patient tracking all rely on the efficient IT system. And without this foundation, even the best care models may struggle to operate effectively. With the infrastructure in place, the program can then move into implementation. And this is where the real work of care CCM begins. So CCM services are delivered, patients are engaged more effectively in their care, and coordination between providers became a central part of the process. And at this stage, the goal to not to provide services, we need to build trust, continuity, and a meaningful relationship with patients who are managing with long-term conditions. And finally, all these steps lead towards the ultimate goal, creating a sustainable CCM program. Sustainability means that programs continue to grow value over time. And financially, it should support practice long-term viability. Clinically, it should contribute to improve patient outcome, and operationally, it should allow the program to grow, scale, and adapt as healthcare system continue to evolve. So, in summary, CCM much more than a billing code or a single service. It represents a structured approach to delivering and coordinating patient-centered care for individuals living with chronic disease. And when implemented thoughtfully with the right contract model, infrastructure, and care coordination, CCM has the potential to improve patient outcomes, strengthens healthcare practice, and supports the broader transition towards the value-based center. Thank you so much.
Thank you so much, Dr. Malaz, for this combo fatty lecture. Thank you so much. But it's well prepared and well presented. Thank you so much for your cooperation and your hard work. And I also want to thank our fellow colleagues, Dr. Ayah, Dr. Malaz, and Dr. Ayah, Dr. Malaz, and Dr. Hala for their hard work and their presentation today. And as we are running out of time, we will now hear from Dr. Nader. Thank you so much.
Thank you so much. This is a great presentation, and thank you for the preparation and the presentation. Thank you, Dr. Ahmed, and your team.
Thank you so much, Dr. Nader.
Any other topics?
I think we still have one topic, but if the time allows, also Dr. Malaz, but if we have time, we still have one topic.
Yes, please, Dr. Malak, go ahead if you are ready.
Are you ready, Dr. Malaz?
Yes, but actually, Dr. Nadir, I need your help because
Sure.
the next topic is regarding the Doximity AI tool, and it's need actually for BAA.
Sure. So I'm gonna share my screen, and hopefully it's gonna work for you guys. But basically, Doximity is an application or website or tool that can be used by physicians here in the US, and it has many benefits. It can keep you up to date with some of the topics discussed or arise, and it can be useful for your specialty if you want to be updated with current literature, current topics. So the home page basically will give you some articles that you can view, or videos or things happening, and you can follow that. It's kind of news or topics, articles about the medicine or the field that you are in. The tool that I wanted you to know about is Scribe, and I'm not gonna share with you because it may have some patient confidentiality. But basically, it's a tool where you dictate while you are talking to the patient. For example, if Dr. Ahmed is my patient, I will go in and I will start the recording on my device. Let's say I have my iPhone. I'll turn the recording on, and then I will ask Dr. Ahmed, what brought you in, or what's going on? What's your concern? What's your complaint? And he will answer, oh, I came because of I have a headache. And the tool can be used in office, and the hospital, in nursing homes, and so on. So it will record what the discussion or the scenario went. Every question I asked and every answer he replied to, or vice versa. If he or his family has some questions, then they can answer, and then I can explain, or they can ask the questions. I can explain the answer in details for them. And when I do my examination, I can also say, I'm going to your heart, so I'm gonna listen to the heart. I use my stethoscope, and then if I find anything abnormal, I'll say you have a systolic murmur, or if it's normal, I'll say heart sounds are normal, lungs are clear, and so on. While you are doing the exam, whatever findings, positive or negative, normal, abnormal, that you want it to be recorded, you just say it, and then the device will pick that up. By the end of the encounter, you will say, this is what's going on, this is our plan, we will do this. And if you don't have any question, thank you, bye-bye. And you go to the next patient. Before you enter the other room, you will hit the end encounter button, and it will process this discussion. It's gonna convert the dialogue between the patient and the physician into a SOAP note, where it will divide. The first part will be like subjective, where the patient is complaining of this, and then if there is any review of system, it's gonna list them. If there is any past medical history, surgical history that you ask about, it will put all this into the first section of your note. The second section will have the objective. If you, let's say, listed some vitals, it will put the vitals, and it will capture your exam findings. It will list it as a physical exam. If you discussed any lab results, let's say the hemoglobin was 8 and we're gonna transfuse or whatever, then it will put that also in the objective, lab reviewed and significant for hemoglobin 8. And then the last two parts will be the assessment and plan, and it can list what's the problem and what did we do or what do we plan to do. In this case, we'll say anemia, hemoglobin is 8, we're gonna transfuse or we're gonna repeat the lab and monitor, and if less than 7, we will transfuse, and so on. So it's gonna create the whole note for you, and it will save it in a list where you will have patient number 1 you have seen, then you go to patient number 2, and it will repeat the same thing. So it's a useful tool, and there are other tools similar that you pay for it, and this one is free for physicians. It has some limitations. So, for example, if I go to see Dr. Ahmad in the room, I say, what's your name? He will mention his name. What's your date of birth? He will mention that. And I can say, I saw the patient in room so and so. When I go and review the dictation, it will remove this identification information. So it's gonna have note number 1, note number 2, note number 3. If I come later and I don't remember which one of the patient I saw first, then it's not. But to overcome that, as soon as you see the patient, the note is ready, then you can enter the title for the note. It will have the time stamp. You can add the patient name, whatever information that you need, so that when you review your notes later, you will have an idea, and it's going to be ready for you to integrate into R or HR, electronic health record, or electronic medical record. So it's just save the time for physicians when they see patients, because one of the major problems with physician in primary care initially or other specialties, the documentation, the requirement, and the burden of it. Because in a clinic, you will see, let's say, 20, 25 patients a day. And for each patient, you want to record their, document their note, and there is no time for you to do that while you are seeing the patient. And most of the physicians will take all this work at home, and then they will complete their notes to requirements by the billing department or by the insurance, or to cover every aspect that they wanted to document for legal reasons and so on. So it's just time consuming for physicians, and in the past, pen and paper was faster. We thought that the electronic version will be more efficient, but it seems it wasn't, and it turned to be a burden on many of the physicians if you work with physicians here in the US. So this tool help reduce the time for documentation. You don't have to sit again for a long time. So you just review the note that was transcribed, and if you need to make any changes, then you do a few edits here and there. And if you are satisfied, then you copy the note to the chart and you will be done. So it's going to be a few seconds, maybe a few minutes. And then within 10-15 minutes, you will have all your notes uploaded to the EHR, which is a significant amount of time compared to hours spent in documenting the encounters with patients, if that makes sense. So it's just one of the tools that are available. There are many other tools similar to this. Some practices, like hospitals or clinics, they hire a person to do that, to do this work. So, for example, I can ask Dr. Malaz to come round with me. She will have either the tablet, iPad, or computer where I will see the patient, and she has a template open in front of her. I'm gonna ask the patient the question. She will put it in the note, and by the time I'm finished with seeing the patient, she will already be finishing the notes for me. Whatever I said or I did, it will be recorded, and then I pay her for that, for example, if that makes sense. So, do you have any questions, guys?
Thank you so much, Dr. Nader. So, Dr. Nader also here, Dr. Rogel actually, who's have the Medicarm website, provided you can say links for some prompts actually for those who not know how to use the Doximity and so on. Can I open the screen and show them?
Yes, yes, please.
Okay. I hope it's clear. So, okay, sorry. Here is the Medicarm actually, where they provided the links and the examples for prompts. Actually, you can use it and help. Wait, let me write here. Yes, here. So here is a sample of prompts, and even so here, for example, link it to the history and physical for the ICU. Okay, here is for example. Firstly, after Dr. Nader said we will going to the open the AI tools and then going to creating the for the docs chat, and then we can start by this prompt. Okay, if we wanted to create the history and physical and for the physical assessment, so we can use the prompt like this, forget every things before, like make it, you can say, remove all the memories regarding the past patients and so on, or even so the memories used before, and this is brand for a new patient, and make a copy paste for all. Here we mentioned like all instructors the AI should follow regarding make the history, and regarding the make the clinical assessment, and follow this systematically like this: history representing illness, review, past medical history, and surgical events, so the examination. And then after that, like we can ask them even so, like if ready, we can share the patient's history. After this prompt, we can share the patient history, your own patient history, and here till this, okay. And after paste the patient history, they will gonna actually give us the all clinical assessment, okay. And then after the clinical assessment, we can use it even so for summarize the patients and know even so the updated assessment and plan based. So again, we will gonna write a prompt like what happened new for the patient and so on, regarding the update and so on, and regarding the clinical findings and so on, the follow up, and even so. Like we're gonna tell them that for example, I'm treating physicians and need you to create an updated assessment and plan based on the new patient information I provide for today, using the current date. If there are if there is previous updates and so on, summarize them as past narrative before, adding today's update and preserving significant dates, events for future reference, and convert present tense statement from the old notes to past tense in the new note, and tell them even so I will provide overnight developments since the late note and our current actions. If mentioned labs that are abnormal, they should be listed as an assessment, such as sodium, potassium, creatinine, the existing assessment and plan format, updating it with the new information. And first, I will share the current assessment and plan, then confirm you are ready for the updates. After I provide the updates, incorporate them into a final note, carrying over all elements from the old note with my changes applied, and ensure the final assessment and plan remains sectional, like neuro with its own assessment and plan and so on, cardiovascular with its own assessment and plan and so on, and make sure all diagnoses have the ICD-10 codes associated with them. And they will gonna give us all the updated assessments and plan and so on. And and then after that, we can make any copy paste for the previous assessment plan. Actually, when actually was paste it for us after giving him the instruction first, the regarding all following this systematically, and then give him the updated plan regarding, for example, overnight the patient improved and was able to come off the vasopressor and so on, blah 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 blah. And yeah, we're gonna give us all the differential diagnosis, the assessment plan, all everything. So I hope so I can use it, unfortunately.
Yeah, it's a very useful tool if
Yeah.
you know how to use it. And in some big companies or big hospitals, big system, they incorporated Dragon dictation system. So in the past, what physicians do or still do in big companies or healthcare system, is when you see a patient, you come to the computer and then you dictate your note, and then the Dragon will also create a note for you. But Doximity is using an AI to help you instead of computer to dictate your note. It's on like at the same time on the fly, they say. And there are different ones. One is called Freed, I think, also another tool. And it depends on the number of physicians working, like in a group, for example. You can pay 100 a month, and you will have this on your computer or your laptop or tablet. And then when also do the same, there are other ones. Thank you so much, Dr. Malaz. Any questions?
Thank you so much.
And as Dr. Malak showed, so what usually in the past, what I do, I write my note, like I come home and I type my note because I have an accent, and when I dictate, sometimes my notes, I have to go and correct them. So I will do the work 2 times. So what I do, I type my notes, but when AI came, I use similar prompt to the ones that Dr. Mark showed you. So I will say to the AI, I will put the AI as a role model for me. I'll say, you are internal medicine professor rounding in a nursing home. This is the first patient. And I don't put identification information like patient name or date of birth or anything. I just say 70-year-old female, and she is complaining of abdominal pain, some urinary symptoms, no fever. The nursing staff mentioned this and that, and the vitals are stable, and the exam was positive for so and so. Complete the sub note and the level of acuity. I'll say level 2 or level 3 or something like that for billing purposes. What it will do, it will look how these sub notes are written, and it will follow that same, like the prompt this was just displayed here. So it will list the patient who are presented with complaint of abdominal pain, urinary symptoms, including this, no hematuria, and then examination is positive for this. Vitals are stable. The assessment and plan, most likely number 1 UTI. Check the urine, check the lab, including CBC, and so on, if that makes sense. So it's just saving time if you use AI to complete certain monotonous time-consuming tasks. Thank you.
Thank you so much, Dr. Nadir. Actually, honestly, I struggle a lot with this documentation, and I really wish I could use it because here in UAE, like, you know that, like, here actually uses the AI, like, in system and so on, but just as AI and technologies, like in radiology and so on, help us in diagnosis and so on, and even so, like in clinical decision, like support. Even so, if when we want to analytics for the patient outcomes and so on, in the electronic health records and so on, but documentation actually literally I struggled a lot.
Yeah, it's time consuming. Yeah.
Yeah, wallahi.
Yeah.
Especially when I was on call. Oh my God, too much
But
actually.
try to use Gemini or ChatGPT or any other AI tool. Use this method. Just put a role. Let
Mm-hmm.
them say you are the internal medicine or whatever specialty, the professor in this area, and you are seeing this patient, and document whatever short sentence you have about the patient, the condition, the exam, and so, and tell them exactly what you want the output to be, like what type of note is it a soap note for you or whatever. And the main goal of that, so similar to the prompt you just shared with us, and see if that can save you time,
Yeah.
and then copy it back to the EMR.
Yeah, thank you so much, Dr. Nadir.
You're welcome. Thanks. Any question for Drs. Malaz or for me or for any other the presenters? If not, I'd like to thank you all for attending this hopefully useful meeting for you guys. Thank you, Dr. Ahmed. Thank you to your team from today's presentations. You did a great job, and thank you to those who will come and watch the recording in the future. I hope you are doing great, and Ramadan Mubarak. I just want to share one announcement. Next week is going to be Eid, so the weekend will be off, and we'll see you in 2 weeks. So hopefully we'll have a good end of Ramadan. I wish you all the best. Happy Eid, and we'll see you in 2 weeks. If you can pass that also to the other fellows, that would be great. Thank you. And if you have any questions, please reach out. You can use the email, text message, WhatsApp, or you can call me. I'll be happy to help. Assalamu alaikum, and have a wonderful day or night wherever you are. Assalamu alaikum. Ya amantillah.
عليكم
Thank you so much,
السلام.
Dr.
وعليكم
Nader.
السلام.
Thank you, Dr. Nadir.
You're
Thank you.
welcome.
Useful for
So
you.
what EMR do you use in UAE? Malaz.
Yeah, in UAE.